Okay, welcome all to this 10th ENT Conclave 2020. As we know, a promise of a new dawn lies in our coming together and being together and working together. Perhaps our greatest strength into the future.
Everybody mute their mics, please.
You all are alive. You can start.
So good. Welcome all to this 10th ENT Conclave 2020. As we know, a promise of a new dawn lies in our coming together and being together and working together. Our greatest strength.
Everybody mute their mics, please.
You all are alive.
Dinesh, there is some lag, I think.
No, ma'am. Don't see the webcast, ma'am. Someone is watching a webcast also. Please, if you are watching a webcast, please close that window. My humble request to everyone. Someone is watching a webcast.
Okay, someone has also opened the
Webcast
general
link also.
Okay,
Please
the
don't
webcast
open.
link.
Kirtane sir.
Should I go ahead, Dinesh?
Please, sir, continue, sir.
Okay, so good morning, doctors. On behalf of Alchem, we welcome you to the 10th ENT Conclave 2020. We thank you for joining hands with us in this mission. And as you know that over the course of the day, we shall have various luminaries who would take us through the most enriched wealth of the scientific cases, the knowledge which will come from them will enlighten us in the field of otorhinolaryngology. And there are significant plethora of insights to dwell on, to discuss, to debate, and finally arrive at conclusions which we hope will act as catalyst in achieving our shared vision. ENT Conclave has been conceived and coordinated by none other than Professor Dr. Milind Kirtane, who is also a scientific program coordinator and is by an unrestricted educational grant from Alchem Laboratories Limited, whom, as you know, have been the makers of some of the most important and supportive drugs contributed from the brands like Clavum, Pan, and Pan-D. Professor Dr. Milind Kirtane, our scientific program coordinator, is a consultant ENT surgeon at Breach Hospital, PD, Hinduja Hospital. Though he needs no real introduction, but it's my pleasure and honor to give a few honorable words for Professor Dr. Kirtane. He is a revered teacher, as you all know, and a man blessed with both healing hands and a caring heart. For his outstanding accomplishment and contribution in the field of medicine, Dr. Kirtane has been conferred with the Padma Shri Award by the President of India. We are especially delighted to present various cases and a path-breaking 10th ENT conclave which will bring out these cases that will begin with live surgery by eminent surgeon of India, Dr. Satish Jain, and coupled with various experts' comments coming from the faculties like Dr. H. Vijendra, Dr. Renuka Bradu, Dr. Devinder Rai, Dr. Nupur Nerurkar, Dr. Amitabh Roy, Chaudhary, Dr. Madhuri Mehta, Dr. Narayan Jaishankar, Dr. Devinder Chaukar, and will be moderated by Dr. Paromita Saha. It is just one more way which we strive to make our experience at this conclave even more richly rewarding than ever before. We do all hope that you will have a memorable conclave. Let us welcome our scientific coordinator to ENT Conclave, Dr. Milind Kirtane. Over to you, Dr. Kirtane.
Yeah, very good morning to all of you. Am I audible? Can you hear me?
Yes, sir.
Okay. First of all, a very good morning to you and warm welcome to this ENT Conclave. We've been doing it every year, meeting at different cities, having interchange of information, operative surgery, panel discussions. This time with the pandemic, we said we shouldn't put a stop to the educational aspect of it, although the social part of meeting in the evening and interacting with your fellow colleagues is going to be put off till next year. So would like to really begin by thanking Alchem for their continued support through their unrestricted grant for education. And they've really been forthcoming without any kind of pressure on us regarding the choice of subjects, etc. They said, we just wanted to have scientific value, and we thank Alchem for that. Would also like to thank Satish Jain as a legend, absolute legend, and you've been watching him, more than 10 to 12,000 people in the world watching him at one time. So it was very nice of him to consent to be a part of this program and demonstrate surgery. The request to him was to show some surgeries which are performed routinely by people so that they take back home to their practice something that they can add to give better treatment to the patients, and some cases which are at the cutting edge of technology or complicated cases. So he's going to do both. Would like to thank Paromita. She's been sort of comparing his programs, and she kindly agreed to do the same for us for Alchem. Would like to thank the panelists who are here, experts, all of them absolutely top class leaders in their field. We have Dr. Nupur Nerurkar, laryngologist, Dr. Renuka Bradu, who is a professor and head of department at the Sion Hospital, Dr. Jay Shankar, who is an all-round ENT surgeon with special interest in skull-based surgery. We have Amitabh Roy Chaudhary, again all-round, but a lot of interest in voice surgery. Devinder Rai, again at Gangaram Hospital in Delhi, but with very special interest in endoscopic sinus surgery. We have Dr. Madhuri Mehta, again an all-round surgeon, fantastic, from Hisar, but very special interest also in otology and skull-based surgery, although she does everything. We also have Dr. Devendra Chaukar with us, who is a surgeon from Tata Memorial Hospital. He's the head of the ENT section there. So Devendra has agreed to join us for this program, although he has said that there may be some emergency for which he may have to shift, and he has said that in case he goes, his colleague, Dr. Shiva, also head and neck surgeon, will join us. So the cases that we have on show today for us, I'll just run through it so all of you know what to expect. A simple endoscopic adenoidectomy, followed by microlaryngeal surgery, recurrent papillomatosis, recurrent FESS surgery for chronic sinusitis with polyps. Then we have a parapharyngeal tumor, a large schwannoma, a carcinoma of the carotid, where probably the facial nerve will have to be sacrificed and resutured. We have a very unusual case, that is malignant otitis externa, which is usually treated conservatively, but there is a definite role for surgery in this. A draft 2, which people should know about because most of the people shy away from the frontal sinus problems in FEST, though everybody is doing FEST. So draft 2 would be very interesting to watch. A subtotal petrosectomy, which is more required in cases of extensive infections or in patients with problems where cochlear implants are to be done, but even for chronic extensive infections and in management of certain tumors in that area. And finally, I said we have to close with the cherry on the cake, and that's a stapedectomy, which is again something that almost all ENT surgeons would be doing, and it would be lovely to watch the expert how he gets these fantastic results. So I request all of you to have, pay attention and join in from now till whatever time it goes on. You know, Satish, we can't keep a time limit on him. So we've said 9 to 6, but it's likely to go beyond. And once again, thanks to all of you. Before I hand over the mic and the floor to Satish, I would just like to say today in the morning, I read the news, 198 of our colleagues, medical colleagues, have succumbed to COVID in their efforts to give service to the people and their patients in spite of the risk to themselves. So we would really like to salute these colleagues of ours, medical practitioners, and give a thought to them and their families in this difficult times. Our prayers are with them. Satish, the floor is yours. Please take over and start. Paromita will take questions and time to time pass on the questions, and we have a panel of experts who will give us their points of view as and when they see fit. There is going to be an interaction all throughout the surgical session. Satish, please carry on.
Thank you, sir. Thank you. And good morning, everybody. At the outset, first, I would like to pay my thanks and regards to Kirtne sir for giving me this opportunity to be here with you all. And indeed, it's indeed a pleasure for me to be part of this event, which has been a very, very high-end academic event by Alchem. It's an annual event, and I have been part of this event earlier as well. Thank you, sir. And the first word, what Kirtne sir told me when he planned this event, to keep a variety of cases to give delegates maximum possible in their routine practice, which can be useful. And this is what is commitment. The man who has revolutionized academics in our country for his continuous efforts for last so many decades. We salute Kirtne sir for his efforts and persistence. Thank you, sir. On this day, again, he made memorable for me to have another opportunity to learn from experts. The people he has called is probably I see as my teachers in my life, wherein I learned so many things from them. Devendra Rai sir has been an amazing endoscopic surgeon we all know in Delhi. He has been organizing so many courses. Renuka madam has been our great teacher. Believe me, my journey into endoscopic sinus surgery started after reading her book on anatomical principle of endoscopic sinus surgery, which I have gone through not less than 10 times. And I highly recommend every junior guy who want to pursue endoscopic sinus surgery to go through those anatomical principle, which is the backbone in learning the endoscopic sinus surgery. Thank you, madam, for such a great gift. And she is known for her innovative work. We know her amazing work in JNA and other endoscopic surgeries. And today, we are here fortunate to have madam and sir for giving us more and more information and their expertise in endoscopic sinus surgery cases. Thank you, madam. Then we have Jhansi Ki Rani with us. Madhuri, she has been amazing in her work. Like sir said, she's an all-rounder, doing amazing cases, amazing workload, and she is published now. She's in the process of publishing her fourth book on autology and lateral skull-based surgery. Amazing, amazing task. Thank you, madam, for being with us. And then my own teacher, Dr. Nupur Nerurkar. Nupur is a great friend, and we all know she's a phenomenal phonosurgeon. Her upcoming conference is coming on, I think, 13th of September, and we are all dressed up for that workshop. That's an annual event, and Nupur has, amazingly changed the concept of phonosurgery through her phenomenal work into this subject. She's a dedicated phonosurgeon, and I have always been in touch with her to learn some more and more things. Sometime, even if I'm not there physically, through telephone, through emails, and so many things, and she has always been so open to teach. Thank you, Nupur. And today we are going to have your expert opinion regarding during these cases. I sincerely request all the people to interrupt me any point of time with your comments, your suggestions, because that is going to benefit everyone, including me as well. Thank you. Then we have Amitabh Dada with us, who is, known for his phonosurgical work besides his expertise in other fields of otolaryngology. And Amitabh, thank you for being with us. Narayan, we all know, he has been in part of our previous webinar. I call him as an accomplished head and neck, the skull-based surgeon. It's not only lateral skull base, but he has a full expertise in endoscopic and open approaches as well. Thank you, Narayan. And this is amazing people sir is called today for the expertise. Thank you.
Satish,
Yes, sir.
we have two more people. I got interrupted by a telephone call. I have to introduce. Pardon me, please excuse me. It's because there was an urgent phone call for somebody that I had to stop. There is Dr. Vijayendra.
Yeah, he is coming.
Who's going to join. And Vijayendra is one of the best, greatest teachers that I have seen in otology. Yes. He has kindly consented to join. Vijayendra, I hope you've joined us. Is he there, Vijayendra? Is he connected already? And the other person from Northeast who have great respect for, who's doing fantastic work in that area, is Dr. Gautam Count.
Gautam is coming.
from
Oh, great.
Assam, absolute committed worker. So I made a last minute request to him and he was kind enough to agree to join. So I was waiting for Dr. Vijayendra to join. If he's not joined, I'm going to give him a call and ask him to join us.
Sir.
Okay.
Thank you, sir.
Okay.
So, as
Satish, did Vijayendra join and go off, or has he not joined us yet?
I think he has not joined us.
Okay, fine.
Probably
I'll
he'll
just
be
give you a
joining
call.
soon. So, today's first case, first case we are starting with is a child with a disease we all know is a very frustrating disease, recurrent respiratory papillomatosis. This child came to us 3 months back with already 3 surgeries done. Then, like we discussed in our previous webinar about the role of surgery and the role of other adjuvant therapies. So this child who has undergone surgery with us as well 2 months back, 2.5 months back, wherein we removed the superficial lesions without going into the mucosa and submucosa at all. And then we followed with the monoclonal antibody bevacizumab injection. Then after the first, this is about the case detail. Then after the first surgery with us, after 4 weeks, we again evaluated under general anesthesia, were having minimal lesions, and we injected bevacizumab again in the base. And this is the third time the patient is on table now. And this is what I'm going to share with us, what we have achieved so far, and what is the current status of treatment of this dreaded disease, which preferentially affects the young children. As far as I know about the disease, presently there is no definite cure to this disease, though with the help of lot many adjuvant therapies, lot many research work done into that, we have been able to achieve much better results what we are getting earlier. But still, there is a long way to go. I had a lot of consultations with Nupur earlier about the various adjuvant therapies. She has a vast experience of dealing with this particular topic for years together. So before going to the Nupur, let us first see what is the goal of our treatment. As we all know, there is no definite cure for this disease. So the goal of therapy is very clear in our mind, and it should be to maintain the airway, because these lesions tend to obliterate the airway, and many of the children come with the respiratory distress because they arise preferentially in the glottis. Then the second is to preserve the voice, which is a very, very important function. And this is something we need to discuss today with Nupur, as the voice preservation is an equally important goal. We are not supposed to destroy the voice by means of a radical surgery, destroying everything, like we're removing a malignancy, that we go radical and assuming that we may get a cure with this removal, which is never going to happen. Rather, if you try to go deep into the mucosa and submucosa, they are reactivating more and more viral replication and leading to more severe problem. And secondly, at the same time, by giving that much of scarring, there is, imminent scarring and stenosis of the larynx, which is something we need to prevent. That is our goal of treatment. So what exactly this disease is? This disease is basically, the virus, when it invades the upper airway mucosa and submucosa, it is between the patient, the host, and the virus interaction that leads to this sort of a disease. Many of the people may be having this virus in their upper airway, but may not be having the manifestation of the disease. So it is purely immune interaction between the patient and the disease, and the goal of the treatment is directed towards immunomodulation, disruption of viral replication, the control of the secondary inflammation, and all is dependent on the neoangiogenesis, which is the target for the future now, because of or by means of various adjuvant therapies. So Nupur, anything you think differently, or the goal is, as I mentioned, to me is very, very, very clear, with the 3-point target: preservation of the function and maintaining the airway. Now What is your suggestion onto it? I will have opinion both from Nupur and Amitabh as well.
Satish, I think the points you've mentioned are absolutely something I agree with, that the aim of surgery, obviously in every patient, would be to maintain an airway, because we all need an airway to survive. As far as the second point you rightly mentioned about having a good voice, that is something which would be targeted from patient to patient, because somebody who is a villager working as an agriculturalist would have a different vocal need than someone who is a professional voice user. So the surgery for voice should be targeted only for the need of the individual, as you also rightly pointed out. So it isn't that we are trying to give the patient a perfect picture. We as surgeons always want to see a perfect picture at the end of the surgery. And that is what we have to really hold ourselves back from. We should not try to aim to see a perfect picture, rather what is sufficient for the patient. So the two important points, of course, which you're going to address and when you do the surgery, is that the anterior commissure should remain untouched, at least on one side, because this is a disease which is going to keep coming and we don't want to create a web. A web is always very challenging to treat. The second point we have to remember is that when we are operating, we never want to go beyond the basement membrane of the epithelium into the SLP or the ligament, because then the papilloma will follow right there and become intralesional. As far as debridement,
Nupur,
yes, Satish.
did this philosophy made you change your technique, surgical technique sometime?
Yes. So earlier I used to stay completely away from the anterior commissure, but what I've realized is if I do that and I don't use any sort of injection of bevacizumab or cidofovir, then the anterior commissure will always be a problem. So therefore now what I do is I will remove all the disease, but I will take out the disease all the way up to one side anterior commissure, go back after 6 weeks and then tackle that opposite side anterior commissure. So I've become more sort of daring with the anterior commissure, and I reserve my cidofovirs and bevacizumab for patients who require surgery more than 4 to 6 times in a year, because every medicine does have its own side effects.
That's a very, very important message from Nupur, that we should not fall upon this disease considering in mind something like radical resection. We need to understand that we have to preserve the function. Like she said, if there is a disease at the anterior commissure, she would do it one side only to prevent the stenosis and come back to the other side after some time. And it looks so, fascinating to remove the entire disease at the same time and get rid of the problem. One cannot. We need to understand the disease, nature of the disease. You cannot get a cure by removal of the disease radically. So Nupur, how do you prevent the, what is your recommendation for preventing the damage to the laryngeal tissue by means of using tools? Like what tool you recommend to remove the papilloma?
So first of all, sure. So first of all, we have to understand that papilloma, unlike polyps and cysts, is an epithelial disease. It's not a subepithelial disease. So we have to remove the diseased epithelium. Now, what do we mean by diseased epithelium is where we are seeing the fronds of papilloma. The virus, unfortunately, may be living in all the normal epithelium also, but obviously it would be ridiculous to remove the normal epithelium. So we remove the fronds. My go-to tool, what you're asking me, is the microdebrider, the laryngeal microdebrider. I find it is very efficient. I use a tri-cut blade, which is very similar to your cutting burr for the initial debulking. And then when you have a carpet of growth on the vocal fold, I use a skimmer blade. The skimmer blade is like your diamond burr. So it has a different motion, and also the rotations per minute would be around 2000. That's up to you to handle. Once I've done that,
any reservation regarding or any role of laser, coblator, or anything you recommend?
Yeah, I'm coming to that. So for most of the people who come with very bulky disease, Satish, I'm using the microdebrider, but I have a lot of adult onset papillomas. In fact, we've just done a recent research where 70% of our patients are adult onset papillomas now rather than juvenile onset. So that's another story as to why that's so. Now in the adult onset papillomas, we are seeing isolated fronds of papilloma rather than, fulminant disease. Over there, I'm very happy to do a subepithelial infiltration and do a CO2 laser microflap. What do I mean by microflap? We infiltrate and elevate the entire frond of papilloma like a flap, just so that we can excise it. We are not going to preserve it. That works very well. Coblation, there are very many people who are happy using coblators. I'm very happy with the CO2 laser, so I don't use a coblator, but there's nothing against using a coblator. I just find it slower, and the wands are not beautifully made to the correct dimension that you want. There are 2 wands available, of course. So my go-to would be the microdebrider, tricut and skimmer, or in isolated fronds, I like to do laser microflap following subepithelial infiltration. Why is the subepithelial infiltration very important? Because you want to bulk up the SLP. As I said, we definitely do not want to lead the papillomas into the SLP, and we don't want to go deeper than the basement membrane. The papilloma is replicating in the basement membrane, because the basement membrane is what is replicating. So the virus will always replicate in the tissue which is replicating, but we don't want to go deeper.
So that the point is very clear. We are not supposed to go too deep unnecessarily. Amitabh, any change in your technique I mean, using the equipments, the laser, coblator, microdebrider, or anything else you recommend?
As far as the tools are concerned, I think as opposed to Nupur, I think we all use microdebrider to debulk the lesion first and then use a laser. That's similar. But for debulking, coblation is also emerging as a good tool, and because it is generally with a good control. But again, you should know how to use. One should know how to use that tool, because this is the one point that everyone is making, that this is an epithelial disease, and we do not want to turn this disease into a subepithelial disease. The number 2 point I want to make, I always tell that I have to have a very good anesthetist when we do these patients, because the tracheostomy avoidance is one of the paramount importance in this patient. Because once unless a patient has a life-threatening, if the patient comes to a tertiary center, then we must avoid tracheostomy, because that is the most important thing.
Yeah, that's a very important message from him, to avoid tracheostomy as far as possible. Like I give you an example, in the last webinar, we demonstrated one case. Are you getting that on the screen? See this patient in the last webinar, 19th of July, this patient we operated as a huge papilloma with hardly any airway visible. And we could intubate, as Amitabh just said, the anesthetist role is very, very important. And ultimately, like Nupur said, we use one and only tool, microdebrider. It looks like completely occupying the glottis and the supraglottis. And see how the debrider is an important tool. You can use a surface debridement without going to the submucosa, mucosa or submucosa. By any means, you can use just surface debridement, and see ultimately we get everything clear rather going into the depth of the mucosa to give scarring and scarring. Unfortunately, these children come with repeated surgery with a lot of scarring already had taken place, and you have to respect that to prevent further deterioration. So this is something I wanted to point out. Like Nupur said, we should avoid deeper penetration of instruments to give laryngeal scarring. Now coming to the next point, besides surgery, these are the things we have been using in our practice together, because we don't have a single cure for the disease. So we have been using every possible thing to have any effect on these papillomas, and these are the 5 things we are regularly using on each and every patient to give I would say adjuvant therapy. Bevacizumab, which I am going to demonstrate today again on this patient, which we have already operated twice. Once operated, second injection, and now the third injection. And the celecoxib, HPV vaccine, the Gardasil 4, we have been giving to all patients, and there are a lot of publications supporting this. PPI and this all these drugs which have an effect on the estrogen, metabolism affecting the papilloma growth. Nupur, your experience using or not using anything, or additionally if you recommend any other thing, because lots of other things are there in the literature which have impact on the papilloma, prevention of the papilloma regrowth. Like you have already mentioned about the cidofovir, we used earlier, but no more now after the bevacizumab. I think you have been using, like you mentioned, still you are using. So your experience, what is your recommendation?
So my recommendations, what I like to follow in my practice, and I want to state here, there is no right or wrong, because nobody in the world knows the perfect answer. If we did, then we'd all follow that. So what I do follow is that patients are all microdebrider is what I use for debulking, or I use a laser. If a patient requires surgery more than 5 to 6 times in a year, then I would go to Cidofovir, because that seems to work better in my patients till
Are you
now.
still using Cidofovir?
If the patient requires 5 to 6 surgeries in a year,
No, no.
or if the disease is
Without,
tracheobronchial.
without the prior use of bevacizumab, your first choice is Cidofovir.
So we have had a group of patients in whom we used only bevacizumab, and a group of patients in whom we use Cidofovir. The numbers, Satish, are very small. We are talking about numbers like 5 and 6 in either group. And the group which had in which I used bevacizumab did not do very well at all. I want to just state here that this is intralesional bevacizumab I used in the patient. In no patient did we do infusion, which I know you're doing, and internationally that is what is showing a lot of result. So now if I was to use bevacizumab in a patient, I would use it intralesionally and also by infusion in 4 to 6 weekly cycles. So that was the difference. As far as the vaccination is concerned, there's no doubt we want to create a herd immunity, and everyone who is more than 8 years of age is vaccinated by Gardasil, or now there are even vaccines which have 9 viruses in them. I do encourage all my patients to have cabbage, cauliflower, broccoli, etc., but I don't give them any kind of medication. As far as reflux is concerned, Satish, there are quite a few papers which suggest that reflux and papilloma doesn't have any correlation. But having said that, in every patient who I operate, I always find that even a little bit of acid is going to cause worsening of the healing. So
Yeah,
post-operatively, I would definitely
this is simply an assumption that the
Agreed.
reflex leading to the mucosal disruption, mucosal irritation, which
Agreed.
can help replication of the virus. That is
Agreed.
the exception.
Agreed. And I really feel the side effects are very few. So I would agree with you that I would treat the patient for reflux. I'm not giving any other medication because I don't think there's any categorically papers which suggest a fantastic improvement.
And out of this list, have you ever used anything which you have now discontinued? Any pros and cons or any experience?
So,
interferon, have you ever used interferon?
No, I've never used interferon.
Because interferon has been talked about a lot in this disease. They are immunomodulators. They modulate the leukocytic activity, the immune response. That's a costly affair as well. The availability is a big issue. And the past literature talks about the interferon a lot, which is now reduced to a significant extent after the introduction of this monoclonal antibody bevacizumab. So for everyone, bevacizumab is a vascular endothelial growth factor receptor inhibitor, which incites neoangiogenesis, and prevention of neoangiogenesis is the goal to prevent the new papilloma lesions. And like Nupur said, had certain reservation about the dosing and the systemic infusion. We went to the literature. Nupur, this is our what we have been seeing in our series of around now, where we have introduced this bevacizumab. We use this in almost 30 patients now.
Mm-hmm.
We started with a low dose for the fear of complications, side effects. This drug has been extensively used by medical oncologists for various malignancies to prevent neoangiogenesis. This is like an adjuvant therapy with the radiotherapy, with the chemotherapy and other things. And according to them, it is pretty safe. What we are using as a local infiltration in toto, we started with 15 milligram and now we are almost using 50 milligram topically for infiltration more and more at various subsites. Sometimes you have a lesion on the false cord, true cord, anterior commissure. Everywhere we are using separate injection. So almost in total 50 milligram we have been using now. And this high dosage regimen, we went to the literature and again confirmed has a positive effect. Secondly, this injection comes with 100 milligram dosing. So what we started using, the 50 milligram is an IV rather than wasting it. The reason is for the more severe papillomatosis like tracheobronchial and pulmonary papillomatosis, the sole treatment in the present literature which is most effective is bevacizumab, and that too systemic, because then you can't use intralesional in the lung or anywhere. And in the dosage schedule, if you go to that systemic doses for the pulmonary papillomatosis, is almost 10 milligram per kg weight. If your child is 15 milligram, you have to give almost 150 milligram IV, and that too pretty safe. The side effect of highest dosing of 10 milligram per kg in long run is 1.5%, and that to minimal hypertension or something like that. So it is absolutely pretty safe, and using a high dose regimen has a positive impact on the overall outcome. This is what we have observed. Yes.
Satish, I just would, because there's so many people who will want to replicate and do what you are showing.
Yeah.
Would you do this infusion? Local injection is one thing. Would you do the infusion in all the papillomas who are coming to you? Are you selecting the people who are very aggressive disease into the trachea, bronchi, or those who require repeated surgeries?
Yeah.
Because even though you mentioned the side effects are not many, which is correct, but there is a 30% and above possibility of proteinuria and WBC counts going down. There is a 10% chance of a nephrotic syndrome. There is a chance, very low chance, but there is a chance of long-term infertility problems in women and effect with their menstrual cycle. So we have a lot of young girls. So is
those
it for everybody?
Nupur, those are I mean a regular side effect profile of a drug when it is used for other purposes, not for papilloma purpose for that matter. If you go to the side effect profile of this drug, innumerable for every drug. Number one. Number two, coming to your question about the papilloma use in papillomas, we have been using this remaining 50 milligram as a systemic dose, which is hardly any, you can say 3 milligram per kg for the child, and the doses recommended for the pulmonary, this papillomatosis is up to 10 milligram per kg.
Yeah, 5 to 10 milligram per kg per day.
This is just for an added effect. I don't know whether it is working or not, whether it is right to use or not, but there is no harm in using, I would say.
I hope you're keeping a complete record, because this will make for a wonderful publication.
That is why I am going to share this second stage of this patient, in whom before 2.5 months we removed the papillomas and injected intralesionally once. Then after 4 weeks, in a planned way, there were minimal papillomas. We debrided, very minimal, and injected the drug again, and now this is the third time. There are a lot of studies done. Yes.
Internationally, what they're doing is, after the first time when you debulk and inject it, the second and third time, if it is not a small child, if it's someone who's above 15 or 16 years old, one can do it as an office procedure where you don't have to take the person under general. Of course, children you have to take under general, but for adults, it's very easy. Like we know how we do injection laryngoplasties, and we can just inject into whatever area we want. So you don't need to give a GA. So you just call the patient into the office and give the Avastin or Cidofovir injection every 6 weeks or 2 months. So it really decreases the morbidity for the patient to a large extent. Obviously in the children, as Satish's patient is a child, he obviously has to take it. Till Satish comes back, I'd also like to add on that Dr. Steven Zeitels has done a lot of research where he has combined bevacizumab along with a hemoangiolytic laser, like a KTP laser, or you have pulse dye lasers, or now you even have the true blue laser. The advantage is that both of these actions work in combination. One, like Satish explained to us, is preventing the angiogenesis, because bevacizumab is an anti-angiogenic factor. The second, which is the hemoangiolytic laser, what it's doing is causing a destruction of the blood vessels without destroying the epithelium, because their wavelength varies from 485 nanometers,
like KTP or argon.
Yeah, like KTP or pulse dye or the true blue laser. So all of them attack the oxyhemoglobin. So the two of them together, Zeitels has published 2 papers in Annals, which has shown a cumulative effect, and you can do it as an office procedure. The fiber lasers, hemoangiolytic lasers are fiber lasers, and so you can inject also as an office procedure. and you can also do the fiber laser. That is after you've done the debulking under GA the first time. Of course, in children, we have to again and again give GA.
Nupur, we are all set with the case.
Looking
Yes.
forward, Satish.
Yeah, and the last thing I want to ask here, how do you treat the adult and the children differently?
That's what I was just saying, Satish, while you had gone to the patient, that in adults, if it is an adult onset papilloma, very often we see it as fronds of papilloma. So we excise it as a microflap, where we take a 0.5 millimeter margin all around. And I feel that a lot of nidus of the papilloma virus is around the papilloma tissue. So by taking a small margin, I feel the recurrence really comes down, following which the adults can be injected as an office procedure if one has to opt for the injection, or we can use the fiber lasers as an office procedure rather than taking it up for surgery. For children, we have to do the GA, and we focus more on the debrider and taking care of the anterior commissure.
Okay. Ma'am, I have a question for you from Singapore.
Yes, Paramita.
Yes, ma'am. So this Dr. Ravi from Singapore is asking, when you raise the microflap, as you said, so will you not be worried about creating a raw environment for implantation of the virus subepithelially?
So papilloma is an epithelial disease. Like I said earlier, the human papilloma virus is growing in the basement membrane, which is the deepest layer of epithelium. So you cannot be considering removing half the epithelium. Technically, you can't even do that. So the epithelium, which has got the papilloma fronds on it, has to come out. There's no question whether it comes out with microdebrider, whether it comes out with laser fulguration, whether it comes out with laser microflap, whether it comes out with coblation. It has to come out. So epithelium has to come out. After epithelium, the second layer we know is the Rinke space, which has got the superficial lamina propria. You don't want to take out the superficial lamina propria. So when we perform an infiltration, we bulk up this area so that we are operating on the the most superficial part of the SLP. There's no question about making it raw. We have to make it raw because we have to take out the epithelium. What we don't want to make raw is both the anterior commissure, both the sides. Up to one side, yes. All the rest over here, yes. Choose any one anterior commissure and keep that spot with the papillomas or with the epithelium. So you can make things raw because you don't have a choice. The epithelium has to come out.
Okay. Okay, ma'am.
Yes.
Thank you.
Hello.
I hope that answers.
Satish, before you begin, welcome Dr. Vijendra and Dr. Gautam Count. Both of them have joined.
Oh, welcome, sir. Welcome, Vijendra, sir.
Dr. Gautam Count.
Hello, boss. Welcome.
Yeah. Thank you. Carry on, sir.
Thank you. Thank you. Are you getting the picture?
Yes, very clear.
Yes, we are.
So, this patient, as I told, come to us after 2 surgeries, 2 or 3, I don't remember. Then we did surgery, the first one, injected bevacizumab, the second one with minimal lesion, again injected in a planned way, and this is third one is again the planned. Now the lesion, what I see here right now is, can you give me the vocal cord retractor? Can you see on the right side? See the lesion there?
Yes, sir.
Can you see the lesion behind, a small lesion?
Yes, sir.
On the vocal, I would say the supraglottis part, the false cord region here. One lesion here and one small lesion here. And look at the vocal cords. This is after 2 injections of bevacizumab, and see the preservation of the vocal cord. Though there is minimal scarring at the anterior commissure, we can observe when we do laryngoscopy, we find that minimal scarring, if you closely observe at the level of the anterior commissure, which had happened earlier. And this dramatic response with the bevacizumab. The first course, we injected 50 milligram. The second time we injected 30 milligram. And today, probably I will be injecting 15 or 20 milligram. Because I will be injecting now only at these 2 places, not at the vocal cords, which have completely gone. Vocal cord, the false cord anteriorly completely disappeared. Only lesion on the supraglottic part, the false cord behind towards close to the arytenoid on both sides. And if you see on both sides lesions, if you go to the what Durkheim's classification is, about the elevation of the lesion. On the left side is the minimally elevated, on the right side is Derkate 2 with the elevated lesion. So my target now today is only these two places. You know, this is again a planned one because we don't want the massive regrowth with resultant, you know, extensive surgery to this particular patient again.
Satish,
So,
before you inject,
yes.
Do you think it is at all possible for you to take a 0-degree telescope and just show us a picture closer to? I don't know whether you do that, but we like to do that routinely.
We can.
So we see the subglottis, we see
Yes,
the
yes.
ventricles.
Yes, that is very important.
Because your injections have done such a good job that the disease is hardly seen now. So if we can see it under magnification,
yes,
that would be great.
And Satish, what was the status of the lesion after the first injection when you went
minimal
into the second
lesions
time?
on the false cord and 2 lesions on the true cord on the left side, and now it is completely disappeared.
And which was how much interval after the first injection? Yeah, I mean the second.
Yes, so what is the interval, sir, between these injections?
4 weeks.
4 weeks.
Also, Satish, do you have a picture before injections?
Yes, I tried to find out, but I will so probably my colleague is finding out. Can you see lesion on the left side?
Yes.
Hello?
Yes, Satish. I think you can see fronts on the left arytenoid, just very few on the medial surface of the left arytenoid. Is that what you're showing us? Is this the same patient you had operated on about a month ago?
Yeah, this is 5 weeks from now.
In your
After that, this is the second injection was given 5 weeks back. Second injection.
Yeah, okay.
So we follow. We don't have a set protocol.
Subglottis, Satish.
Yes, yes. Yeah. We can't establish a set protocol so far because of the varying, you know, recommendations and varying protocols from the literature. Let me remove this.
This telescopic picture which Satish is showing us, it's great to take a photo with it pre and post and give the patient in cases like this which recur. So even medical legally you show them that you did do a debunking, because this disease comes back, Satish, so aggressively that sometimes a patient can say, "Aapne to kuch kiya hi nahi." You know, same with keratosis.
Yes.
So it's always a good idea to give them those photos.
Yes, that is very important. Now see, I am going in the subglottis.
Yes. Lovely.
That looks
We're just seeing
lovely.
but
There's
very
nothing.
nice, very clean.
And earlier also he didn't have any lesion in the subglottis. Okay. Now the only 2 areas, that too having minimal lesions, and still I don't want to lose this opportunity to inject again, because otherwise it can come back with the same problem. Because this disease, we all know, is so frustrating. So there are some studies who did 5 injections of bevacizumab at the interval of 3 weeks, irrespective of the status. Some studies did 3 injections. So what we have started doing, after the first removal and injection, a second planned definite injection after 4 to 6 weeks, and the third planned, you know, endoscopy, microscopic evaluation again after 4 to 6 weeks. If there is a smallest lesion, inject. Now, once there is a small lesion, I will inject today, and again we'll see after 4 to 6 weeks. If there is no lesion, we'll observe. As simple as that. But not following with this infiltration and allowing the lesion to flare up to give the same problem, and then same major surgery, same, allowing the scarring and all the thing, everything is not something I would say recommendable.
What dose are you injecting today, Satish? Last time you injected 30.
Yeah, so even less today. Even less today.
20 or 15?
Yeah, 15 or 20.
Good, great. Sometimes these injections, especially I know in Cidofovir, in a doctor patient actually, repeated injections took care of the disease but caused massive scarring of the superficial lamina propria. I had not done those particular injections, but the doctor's following up with me because his mucosal wave is almost absent. So, you know, as Satish is very rightly saying, if the disease is quietening down, he is decreasing the dose also. So that is a great idea. It makes sense.
Ma'am, what is the reason for repeated recurrence in spite of adequate clearance? Is it the strain of the virus, and do we send the specimen for viral analysis?
Paramita, good question. Yeah, so one is we must always send for viral typing. The first time the patient comes to you, not only histopath, you want to know whether it's 611, which is acceptable, or whether there is 1618. So we do a viral typing the first time. We don't repeat the viral typing unless we feel the disease pathology seems to be looking a little different. The histopathology also we don't do every time, we do it every third time, but there's no harm if you want to do it every time. Why we do it every third surgery is in case dysplasia is developing in or a carcinoma in situ is developing. Why does it recur? The whole problem is that the HPV virus is living in the basement membrane of apparently normal looking epithelium, which we've left behind. And therefore it grows. So therefore what Satish is doing, even when everything's looking more or less good and healthy, he's not only going to inject in the small areas, but a little bit all around. So the idea is to prevent, in this case, angiogenesis from taking place. So to prevent any possibility of that virus, which is present, which we can't see, from again growing back. Same principle for side-off-over injection.
Okay. Yes, ma'am. Yes.
This is right in the base of the lesion. I am not debriding it today. This is already almost close to the surface. The further debridement would allow the surface to,
become raw.
Yeah. See this?
The injection needle you're using.
Yeah, this is what I'm using is the PCNL needle, which we get from our, urology friends.
Okay. We
This is
have
fine PCNL needle, and see the lesion where I injected. This is 10 milligram.
10 milligram. Okay.
And now on this side, see the lesion on this side? Go to the depth of the lesion, just in the depth of the lesion. See this?
Yes.
See this?
So in the SLP is where you're injecting, which is just deeper to the basement membrane.
That's it.
For people who don't have a PCNL needle, you can simply use a scalp vein by cutting the butterfly flanges.
Yes.
And here you can use a 25 number needle, because don't use very fat, because it's a very thin liquid you're injecting. Or you have 26 number long infiltration needles, which are locally available for 500 to 700 rupees, which we use routinely.
Yes. Now see, I've injected 20.
Excellent.
Without removal of the lesion. And this again, after 4 to 6 weeks, we are just going to see this, whether the lesion is coming or not. See this elevated lesion a little bit. It prompts you to remove it, but believe me, it is not needed. This is generally the level to which we reduce in our initial surgery.
Okay, Satish,
Rather than going to the level of the mucosa. Yes, madam.
do you take certain special precautions to avoid any laryngospasm in the post-operative period in such cases?
Never faced, because we have already given a dose of steroid
Okay.
at the time of intubation.
Okay. Okay.
So this is what the injection in the base of anti-neoangiogenesis factor, and this is what needed in this situation. You remember the last case, then on the 19th of July, we'll keep it after 2 weeks. You have all seen the kind of, extensive lesion it was. And after 2 weeks time, you'll see how it regresses the same patient. It is dramatic. Believe me, it is dramatic. Besides this, not only this, the first time when the patient came, we gave him a dose of Gardasil, which is to be repeated after 2 months and then 6 months. The 3 doses of Gardasil, that carries, that's a quadrivalent vaccine against HPV 6, 11, 16 and 18. There is a bivalent vaccine introduced earlier that is against 16 and 18, that is Cervarix, that is to prevent the cervical cancer. This is for additionally for the papillomas as well. And nowadays the nonavalent vaccine has also come against the HPV strain 31, 33, 45, 48, 52, so many. There are more than 100 HPV strains discovered. And these vaccinations, there are certain publications showing the amazing immunity against HPV with three doses of vaccine in a known case of papilloma as a therapeutic use, not for prevention, as a therapeutic use. Secondly, we are giving all these pediatric patients the celecoxib, 100 milligram to these pediatric patients every day for at least 3 months. These papillomas are known to have, the COX2 receptors on which the celecoxib acts. And this is a good strategy to use as an adjuvant therapy, celecoxib, for these patients. So amongst the other therapies, a lot of people even recommended MMR vaccine, mumps vaccine, intralesional, so many things, but the effects has not been observed in the long studies. So this is the 5 things which we have been doing, which have proven to be efficacious against majority of the papillomas, and we are using all them together because we don't have any cure to these patients.
Satish, may I mention a couple of things?
Yes, please. Before you carry on, and our next case is ready. That is a adenoidectomy, which we have already induced, and we are going to start in a couple of minutes. You carry on, Nupur.
Yes. Thank you, Satish. So when we have disease in the anterior commissure, what we mentioned is that one can remove all the way one side anterior commissure. Just want to mention that please don't give these patients post-operative voice rest, because when you give voice rest, the chance of synechia formation are more. So don't give these patients voice rest at all. Secondly, Madhuri asked a question about laryngospasm, which doesn't happen very routinely, but we do a very simple thing of a spray with 10% lignocaine just before extubation to prevent a laryngospasm from taking place. And thirdly, want to mention the role of vaccination is really important in creating herd immunity, which will come in 10 years down the line if you start vaccination for all the girls, even if they're only girls and not boys. But vaccination is not therapeutic. What most of the papers suggest is the chances of the individual from getting a new viral infection will be absent, most likely, and also the present or existing virus disease becomes a little less aggressive. That's what most of these studies suggest, because for vaccination, it's not possible for it to be therapeutic, as we understand.
Okay.
I'd like to thank Satish for a great job.
Ma'am, I'd like to take few questions quickly before sir comes in for the next case. There's a question from Malegaon by Dr. Mohammed is asking the role of CO2 laser versus the argon laser.
Paramita,
Yes,
Nupur has already mentioned, and we have already so many times mentioned, the lasers have practically no role because we don't want tissue damage. Number one. Secondly, she has already mentioned the lasers, the visible lasers having affinity for the hemoglobin to target the vessels have some role, like argon laser, KTP laser if you want to use. But now once you are using the neoangiogenesis factor, there is practically no point in using all those lasers. Now coming to the last point, once you do a papilloma case in a theater, you should avoid taking any other case in the theater further for the day. You have to change the laryngoscopes and all. You have to change the circuit as well, because they may be harboring the papilloma in the fumes if you have, fulgurated, if you have debrided, if you have used laser or anything which is creating fumes which can come in the circuit. So this is something, an added precaution we must take once you do such a case, because to prevent, the cross infection to the other patient. This is very, very important. I don't know how, Nupur, is your recommendation, what you have been using in your theaters for all this?
I just have a question. Sorry.
Yes, please.
Satish, have you ever been concerned about any occupational hazards if you keep on operating on papilloma? Because you said
yeah, you have to be careful. You're right. You have to be careful, particularly when fumes are generating. So earlier we were very cautious, but nowadays we are not using anything creating fumes. Otherwise, you have to be wearing the protective equipments to prevent, inoculation.
Yeah.
So we fumigate the theater after papilloma case, and we do a double sterilization of all the equipment. But we do a case then after. But as Satish very rightly said, it's very important to change all the circuitry. It's also very important for the surgeon when you're using a microdebrider, and especially in the COVID era, to use a PAPR, PAD air purifying respirator, which I am begging Satish to buy and start using.
A few surgeons, madam, wants to know what can be the cost of this injection per sitting?
So the cost of cidofovir injection is about 90,000. We don't dilute the vial, we keep the same vial, and then we use the same vial for the next, after 3-4 week injection and after 3-4 week injection. So it will work out to about 30,000. And similar cost of 24,000 is for bevacizumab, but Satish manages to get it some 18,000 thing he had mentioned.
8,000 something. 8,000 something. 8,
so that he will let us know what is the name of that bevacizumab.
Okay.
We can put your question, Pramita.
Yes, sir.
Next case as well.
Yes, sir.
I'll take whatever question you are having in your right now in your mind. Before that, we are all set with the second case. This is adenoidectomy. At the same time, the third case is again going to be a microlaryngeal surgery. So this case, because these are the small cases, children, which we want to keep in the beginning, and then we'll carry on with our long cases. So our next case is a adenoidectomy, which we are all set on the table. This is rather adenotonsillectomy for the obstructive pathology. Paramita, what was your question before we move on?
Sir, there was a question from Dr. Kaustubh Das from Kolkata is asking any role of bevacizumab in laryngeal hemangioma recurring after sclerosant injection.
Yes, not only hemangioma in the larynx, anywhere in the body.
Okay.
Not only hemangioma, any vascular lesions. Like I've been using, for the hemorrhagic telangiectasias in the nose. Many of those patients have been cured. Even some of the patients didn't come after the first injection. It is so dramatic. You inject some mucosally, this injection, and it is something like a magic. For Osler-Render-Weber syndrome, or what we call it a hereditary hemorrhagic telangiectasia. For that matter, any vascular lesion, this has a role. Locally, systemically, and same way it has been used initially, how it was produced at an anti-neogenesis factor for the malignancies as an adjuvant therapy, post-surgery, post-radiotherapy, along with radiotherapy, along with chemotherapy in various ways. So it prevents neoangiogenesis, and looking at that role, it has been used for many other indications as well.
Okay, sir. Okay, sir. Sir, I think no more important questions. We can move with the next case.
Okay, and you can interrupt any time in between. Are you getting the picture?
Yes, sir.
Okay, let me tell you about this case first, and then there's a very, very important, and very common pathology we see in our practice to treat. That is enlarged or hypertrophic adenoids, but that is not the only indication. First of all, let me show you the picture and something about this case. This is a 7-year-old child. 7-year-old child who presented with a history of mouth breathing, snoring, had adenoid facies now, and now he has come for this treatment of adenoids, and see the tonsils. They together are giving him the snoring and the mouth breathing. So number one thing, adenoidectomy, as we all know, is mostly indicated for obstructive indications. And for obstructive indications, age is no bar. We have done adenoidectomy in a 1.5-year-old child. We have done adenoidectomy in a 25-year-old man. So age is no bar. Whenever there is an obstruction, obviously you have to take care of it. Particularly if it is endangering. Particularly in children, they present with like OSA. Many children we have seen with a back pressure rising, sort of core pulmonale with the pulmonary artery pressure shooting up, and those are the real indications in those situations. So obstructive in general are the common indications, but that is not everything. Obstructive are not the only indications for this surgery. There are so many other indications which we need to know. And believe me, in our practice, non-obstructive indications nowadays are more prevalent as compared to the obstructive. So by and large, we divide into three categories. The one is obstructive. Obviously, you have to remove the adenoids, which we are going to discuss today. And the other are non-obstructive indications. The two important categories is one for the repeated otitis media or otitis media with diffusion, with no obviously, so much of enlarged adenoids to give obstruction. And third is in pediatric population with recurrent rhinosinusitis not responding to medical treatment. And once it comes to surgical aspect, the adenoidectomy is the first surgical answer rather than directly venturing onto the face. The reason for that has been proven in a lot of meta-analysis, as the adenoids harbor biofilms which ultimately aggravate or perpetuate the chronic rhinosinusitis, and adenoidectomy as a surgical treatment in many of the patients avoids a formal sinus surgery in pediatric population. So there are three indications. So coming to the adenoidectomy, number one, how to carry out the adenoidectomy, a comprehensive adenoidectomy, and that has multiple goals. The goal is to remove comprehensively, number one, to prevent complications and to prevent so-called recurrence. For everyone, adenoid is just an hypertrophic lymphoid tissue, which normally has an immense role being a part of Walde's ring in children to combat, or as a part of the immune system, you can say, to deal with the allergy and inflammation which are very, very common in children. So adenoid tissue is just a hypertrophic lymphoid tissue. 60% of the component is B lymphocytes and 40% is T lymphocytes. Almost 3% are plasma cells. So it is just conglomeration of B and T lymphocyte. That's it. And it responds to allergy and inflammation and get hypertrophied. So it's a sort of vicious cycle, I would say. A persistent allergy or recurrent infection, inflammation leads to adenoid hypertrophy and then further symptoms, number one. And number two, adenoid itself, if they enlarge, obstruct the airway, they can precipitate the allergy and inflammation. So it's a sort of vicious cycle. So in order to break this vicious cycle, majority of the patient who is coming with the obstruction, we need to comprehensively clear the adenoids, number one. At the same time, post-operatively, to treat the adjuvant pathologies like allergy or any source of inflammation, lack of immunity, all those factors need to be treated post-operatively to prevent the so-called recurrence. See, this is not a tumor which can recur. This is a simple hypertrophic lymphoid tissue which if removed completely and the cause is taken care of, cannot come back simply. And this is such a rewarding thing if managed properly. So today, my goal is to demonstrate our technique, which we have been using for years together, used in thousands of our patients, to comprehensively clear the adenoids, to prevent the complication. There are so many important things in the surroundings when we remove the adenoids, when we remove them, and you have to protect all those structures at the same time. And third thing, to prevent the possibility of so-called recurrence. See, a partial removal of the adenoids with not treating the cause behind it is the commonest cause of the so-called recurrence. It cannot recur. It's not a tumor. We have to address the pathology behind the development of the adenoids, and most of the time it is allergy. It has been proven. The IgE-mediated mast cells have been recovered from the adenoid tissue in those patients. And if those allergy part is taken care of, along with a comprehensive removal of the adenoids, you can certainly give, a long-lasting effect or a cure to these patients majority of the time. Third thing is the airway. In children, particularly young children, the airway is sometimes so narrow. You have to be careful to prevent trauma to the surrounding structures. in these patients. Wash. Yeah. Can you see the picture of the adenoids? This is without any preparation. No use of any, the topical adrenaline or anything. No injection, no infiltration, nothing. This is a simple primary picture. Be careful while doing adenoidectomy to prevent trauma to the nasal mucosa, to the turbinate septum, to minimize the trauma, to prevent the possibility of synechia in the post-operative period, which is something, again, a very frustrating thing to treat, because these children, you can't expect to follow with douching judiciously and all those things, and you have to be very careful during surgery to prevent the intraoperative trauma. That is something very, very important to keep in mind from the surgical point of view. So what I'm doing, decongesting the nose, knowing the fact that these children are known to have narrow nasal spaces, or instrumentation is very, very important. Still, in over 90% of the patients after the proper decongestion, we have been able to use the 4 mm regular endoscope in those patients, over 90% of the patients. Otherwise, we may have to resort to a 2.7 mm endoscope. At the same time, see the instrument what I am using is the autology cuff forceps to prevent the trauma to the surrounding mucosa. Now I am using a adenoid pack from behind as well, just to decongest the surface mucosa. Now coming to the surgical technique. Now my goal is, first of all, comprehensive removal. It's not just the surface debridement to open up the airway. Majority of the adenoid surgeries are being done like that. You remove from the surface, the airway opens up, and initially the child recovers from the symptom he presented with obstruction, but that is not something, a long-lasting, treatment to the patient. So our goal should be a comprehensive clearance. Yes.
As you're doing adenoidectomy and tonsillectomy in the same patient, do you change the position? Because in adenoid, you may not be giving extension.
Yeah. Adenoid is a regular sinus surgery position, reverse Trendelenburg position.
So once you do the adenoidectomy, you change the position.
Yes.
Then tonsillectomy.
Okay. Yes, obviously.
Okay.
And see, there are so many techniques prevalent for the adenoidectomy. So many techniques. Earlier used to be done by the adenoid curate. That used to be most of the time a blind procedure. You curate out something, open up the airway as you get some tissue out, but this is never long lasting, and these children would again come back with a so-called recurrence. Then with the advent of endoscopy, there are a lot of new tools coming up with a direct visualization during surgery, like bipolar cautery, cobblator, debrider, so many tools, harmonic scalpel. People are trying each and every possible thing to remove the adenoids. This, our technique, is a combination, I will tell you the reasons why, is a combination of cobblator and micro debrider for this purpose, special purpose, for comprehensive removal, at the same time prevention of complication. Comprehensive removal is a sort of, you can say, radical removal, at the same time preservation of the function, because in the vicinity all around are musculature, vascular structures, the soft palate, so many things in the vicinity all around. See, this is after initial preparation. So I will tell you why we are using a combination of cobblator and debrider. Obviously, the cobblator is the most fascinating thing you can see nowadays, as it gives you a surgical experience without any bleeding. And that looks fascinating in the adenoid as well, because a lot of people are scared of bleeding in the adenoids, and these children, particularly very, very young children with low blood volume, you can't expect too much of blood loss, and that's why everyone is, going towards the cobblator. But the only concern with the cobblator is the charring, particularly charring in relation to the critical musculature, the soft palate, Eustachian tube, and if you give charring and resultant fibrosis is never acceptable. So we don't use cobbleter extensively right from the beginning. At the same time, the microdebrider is a great tool in terms of it expedites the process, but the drawback is the bleeding. So we have to use these two things judiciously together to get the outcome. We'll be using the microdebrider in the beginning to get away the maximum bulk of the adenoids, and then right on the surface I will show you how the debrider can be used, and then in between the cobbleter would be used, which is much better a tool for coagulation than any other thing for the hemostasis in between. Cobbleter we never recommend for dissection as it leads to fibrosis, and that is inevitable. If I use the cobbleter at the end of the surgery surface everywhere, the resultant fibrosis may lead to cicatrization and can lead to nasopharyngeal stenosis even. It has been reported. So this demonstration is to show a technique how you can prevent all the complication and get the adenoids completely out. So this is something important to understand. This is a very, very common surgery. See now, my red 60 debrider blade is coming from the oral cavity. Can you see?
Yes.
This is red 60 sinus blade.
Satish,
Yes.
so you must share with the audience what you are using 0 degree through nose and
Yeah.
coming.
Yes, 0 degree, regular 0 degree sinoscope through the nose, and regular 60 red 60 sinus blade from the oral cavity. And this first phase, I will accomplish this surgery in 3 phases. My first phase is the fastest one, wherein I am going to remove this bulk of the adenoids quickly, because using the microdebrider is going to result in some sort of bleeding. So the faster you accomplish, the lesser will be the overall bleeding. So my first phase is the debulking, I would say. I will quickly carry out this debulking in few seconds, and then we'll come on to the area of interest, that is the surface where these adenoids are attached to on the nasopharyngeal surface.
Yes, sir. So Dr. Sandeep Karmarkar is asking, we have been doing the same technique with great result. Have now described as combo adenoidectomy. Any comment on this?
Yeah, you can call it combo.
Okay.
See now, my constant irrigation is coming through my assistant all the time to maintain my visualization, and this is warm saline, which helps in hemostasis as well, as I'm using a tool which results in some sort of bleeding. See on both sides what I intend to prevent? The damage to the Eustachian tube. Can you see on both sides? This is the Eustachian tube torus, this is the Eustachian tube torus, and see the adenoids on the surface of the Eustachian tube torus. So this is my first phase with opening up the airway. This is just opening up the airway. Wash. Can you see?
Yes, sir.
Even if you do this, the child no longer remains a mouth breather. It opens up the airway. See this? And majority of the people end up, this surgery at this point of time, and it gives a result, instant result, by means of opening the airway. See this minimal bleeding with the torus on both sides, under vision, protected, and a lot of adenoid tissue attached onto the surface of the torus. There are a lot of publications, citing the laterally hypertrophic adenoids section. Laterally hypertrophic adenoids cause of otitis media or autologic problems. See now what I'm using, my saline adrenaline saw gauze onto the surface for few seconds. This I'm going to leave for few seconds for the decongestion. Okay? See this gauze for few seconds.
Satish?
Yes, sir.
Just wanted to know, you use a nasal approach, and yet you said that there's a lot of, there's a possibility of nasal synechia formation. So
Yes.
why is it that you use this approach and not the other approach per orally?
Yes.
And taking the catheters to elevate the, retract the soft palate, and then totally doing the same thing under visualization without entering into the nasal cavity at all. Because small children at times it's quite difficult to put in the endoscope in one side and then do it, after all, you're doing that perorally, the microdebrider.
Yes, sir. You're right. That's why I already pointed out that you have to be extra careful. You have to be extra careful while using the endoscope through the nose to prevent, damage to the mucosa. But it has an advantage of giving you
Yes.
a true picture in the 0 degree of obstruction. What otherwise you get from behind is not the true picture of the child which is experiencing as far as the obstruction is concerned. See now, after the first phase and the packing for few seconds, can you see?
Yes, of course.
This is the remaining adenoid tissue, and it looks like adenotectomy done. You see the prominent tonsils below. See, my irrigation is the main tool for hemostasis, and there is hardly any bleeding now. Now this is my first phase. Now the actual adenoidectomy starts in the second phase. My second phase focuses the adenoidectomy in the center, and the third phase will follow laterally. So in second phase, what I mean to say, what we call it this term as a comprehensive adenoidectomy, to remove adenoids in the plane. See, what is there behind the adenoid tissue is the nasopharyngeal musculature. And separating from the musculature is a thin facial layer. We call it as a perimysium. See this adenoliths in between. These are just aggregation of the bacteria which calcify and lead to this adenolith like tonsilloliths, and they are the source of propagating the infections. So
yeah, that's where the biofilms are basically.
Yes, biofilms. Exactly, sir. So now, in order to do the second phase, this is the most important phase, I would say, in order to get rid of this adenoid tissue completely. See, if we leave this much of adenoid tissue with the ongoing allergy and infection, this is bound to come back. So what you need to do to remove completely in the plane. My target is to remove the adenoids completely in the plane. I can do this bloodless with a coagulation as well, but my coagulation will inevitably result in charring the surface behind. And behind is the musculature, which I don't want to damage. That is not our target. Our target is adenoid only. So how you can remove in plane? See below, this is oropharyngeal mucosa, and what on the surface projected are the adenoids. What I am using the same red 60 blade. Now I am using tangentially. See this tangentially at one place I am trying to get into the plane. See, my cutting edge is towards me, not behind. I don't want to damage the musculature behind. So what I am trying? Keeping my cutting edge towards me. We never recommend the so-called adenoid blades because that has a rear cutting edge, and that is something beyond control, and you can damage the tissue behind. So at one place, see, going parallel to the oropharyngeal mucosa, just going parallel to the oropharyngeal mucosa, I am trying to develop the same plane, and then I am going to go up. See, in few seconds you will find the perimysial plane. Can you see this plane coming up?
Yes, sir.
See, all this tissue over this plane is adenoids. Only thing what I am, experiencing, if not using the coagulator, is a little bit of the oozing. At this cost of the oozing, I am able to prevent damage to the muscle, and that is what I want in long run. And we can, pay the price of this little bit of the oozing at the cost of preserving the function. Because, see this perimysium behind, very clear. See the fascia plane. Can you see? Can you see the facial plane?
Yes, sir.
And see, my cutting edge of the blade is towards me. So it cannot damage anything behind. Now I am more and more going up, over the perimysium. My goal is to see my layer of perimysium behind. absolutely protecting the muscle, which is otherwise not possible by any means if you try to remove the adenoids comprehensively. But now, see the change now. As I go up, this muscle ends and the basic occiput with the periosteum comes. How you can differentiate? How you can differentiate? Find out. See, this is the muscle. See, this is mobile structure. And what is there above? See this? This is the basic occiput, which is not a mobile structure. Can you appreciate the difference?
Yes, sir.
So as I go up, now I have no fear of damaging any muscle. Can you see? I have no fear of damaging any muscle.
Yes.
See my irrigation. This is not bleeding. This is pure irrigation going on. Now see above, this is my periosteum plane. Can you see? Now since there is no muscle, I am staying little radical, combing through the periosteum. See, literally combing. Hard combing through the periosteum to remove each and every bit of adenoid, because here I cannot damage the muscle. There is no muscle superiorly. Muscle is ending here. Muscle is ending here. Until then, I use in the perimycial plane very in a conservative way, protecting the perimycium completely. And above that plane, see this, that is the periosteum, where I am combing it very hard to get rid of each and every bit of adenoid tissue. I am not scared of damaging the periosteum here. The reason is periosteum is too resilient to be debrided by the micro debrider. And see, you can see the underlying periosteum and the basic occiput. Now see the difference after the second phase. See, this is after second phase. See after the second phase. Can you see the perimycium below? Hello?
Yes, sir.
And the periosteum above.
Yes, sir.
See, this is to give you an overall picture after the second phase. This is not all done. Now what all again I will do, like I did after the first phase, I will pack with a, the saline adrenaline gauze for a few seconds again. And then I will show you the clear picture of the periosteum and the perimycium. Above is the periosteum, below is the perimycium, and you need to understand the difference. Because on perimycium, I have to be careful not to damage the perimycium. As long as the perimycium is intact, your musculature is perfectly intact. Above the periosteum, you can comb through the periosteum hard to remove all adenoid tissue. Now, what is the implication of these two differences? On the perimycium, if you keep the perimycium intact, there will be hardly any bleeding, because bleeding coming from behind is restricted by a layer of perimycium, number one. And you are not supposed to cauterize that surface too much to, coagulate the muscle behind. That is why we are not using the coagulator, because I don't want to char the muscle at all. Many a times you must have seen, I have seen in my practice, children got adenoidectomy done, who come back with a nasal twang of the voice, with nasopharyngeal stenosis, so many things. That is because of trauma to the surrounding muscles. As long as the muscles are intact, there is no residual damage, and these complications like nasal twang, which may be a little bit as you open up the nasopharynx initially, but it never be long lasting in case your muscles are intact. And the most important is the nasopharyngeal stenosis. Infection, if you damage the muscle, we have seen even a patient got an adenoidectomy, the muscle was damaged and presented with a torticollis with retropharyngeal abscess. Every complication can be prevented if you stay in the perimycial plane and prevent the charring of perimycium. So that is my goal, and that's why I purposely used micro debrider. We paid the price of a little bit of the bleeding, but in long run, this is amazing. See now, this is after second phase. Can you see this?
Yes, sir.
See the plane of the oropharyngeal mucosa. See the plane of the oropharyngeal mucosa. This is my coagulator now. I told you we will use coagulator in between for the minimizing the bleeding. See this minimal use. This is much better than any cautery as it is always, irrigated. See the minimal use of coagulator, the perimysium is pretty intact all the way. Can you see this?
Yes, sir.
And here the periosteum. Now I told you a post-operative hemorrhage can be one of the complications in adenoid surgery. And knowing that fact, we need to do something during our surgical technique as well to prevent the post-operative hemorrhage. Post-operative hemorrhage may happen as the vessels may open post-operatively. Now, as long as your perimysium is intact, no bleeding can happen from this area. And the muscles contract and the bleeders close. In contrary to that, the periosteum doesn't have that ability to contract. And if you go retrospectively, majority of the bleeding in adenoids is coming from superiorly from the periosteal area because this doesn't have an ability to contract. And since we want to protect the periosteum, perimysium with the muscle behind, periosteum is not so important as there is no muscle behind. So what we do here, we prophylactically coagulate. It's a sort of carpet coagulation of the periosteal surface. Only selected periosteal surface, not the perimysium at all, because we don't want to char the muscle. And why prophylactically? As we don't want any bleeding from the periosteal region. And this carpet coagulation has amazing advantage by means of ruling out the post-operative bleeding with no morbidity at all, because this is coagulation of the periosteum, not the muscle. Now see, after this, there is hardly any bleeding. Can you see?
Certainly, Satish, I think it's a very good technique that you demonstrated. And but like I have definitely been using coagulation for the last maybe I don't know how many years now.
Yeah.
And done about 2,000 of such cases, adenoids I mean. And rhinolalia is a factor which I have faced in about 3 patients, but they all recovered within about 3 to 4 months.
Yes.
And but there was never have been post-op bleeding at all. And if you restrict yourself to the perimysium and you have the right planes, because that's what any surgeon would be respecting.
See, what I intend to respect is this muscle behind. Now, without using the coagulator, this is 100% protected, not coagulated. With coagulation, this is inevitably charged, which may have implications. Like a person like you with the expert hand may not have that much of incidence, but this is something has an issue. And we are here striving for the best, for the technique which should be replicable by even the novice surgeon in the safest way. That is why we never advocate using anything on the perimysium to protect the perimysium and the muscle completely to prevent post-operative complication.
Satish, this is what I had wanted to say about you, that in your hands it looks fantastic, but I'm quite sure that a learning curve is required to that technique also that you're adopting. And the same message goes for everyone. Everyone has to respect the perimysium and the muscles and the pars ridge. That has to be done.
Sir, if perimysium is injured, how can we handle it?
The perimysium?
Yeah.
Obviously, you have to coagulate. There is no way.
Yes.
Okay.
And that is something, inevitably, something will be inviting some fibrosis, scarring, and all those problems are certainly need to be avoided. That is what we are emphasizing. Now my third phase is starting, which is again being neglected by majority of the people. That is laterally hypertrophic adenoids. And this has been, you go to the literature and in our huge series, is been a major cause of so-called recurrence, so-called repeated ear problems. You know, many a time this adenoidectomy is done along with a ventilation tube insertion. For the recurrent OME, and you do an adenoidectomy, insert the tube, and again the same problem persisting. And one of the cause for that is laterally hypertrophic adenoids, and the biggest cause of non-removal of these adenoids is the fear. It's the fear of damage laterally, and this is what I am going to emphasize, how you can remove it in the safest way. And this is very, very important. Then only a comprehensive adenoidectomy will be done. See now, again my red 60 blade. Can you see?
Yes, sir.
Now my phase 3 starting. I am pressing on the musculature. This is my, the torus tuberis. This is adenoid tissue over the torus. And this is the adenoid tissue behind in the fossa of Rosenmuller, which I want to remove. The muscles in the midline, this is longissimus capitis muscle. And laterally, I will show you the thick muscle layer, that is rectus capitis anterior. And in between these muscular envelope, we have to remove this adenoid. We are not supposed to go out of this muscular envelope to damage the vessels. So the fear factor is a huge one, particularly working laterally, the fear of carotid artery and all that. I will show you the relationship of the carotid and other things without, terrifying with all those things. So now my first thing is press on the muscle behind and using, see, at a lower speed, control speed, allow the adenoid tissue to fall into your blade. What I want, press on the muscle. I don't want muscle to come in. See this? How much of the adenoid will leave behind? See this? Always keep the cutting edges in view. Don't push your blade too in blindly. Press on the muscle and allow the adenoid tissue to fall into the blade. See this? This is the technique to add on to the safety. Yes, madam.
Satish, that answers the question asked by Dr. Devinder. Why are you using through nose? Because you can see the cutting edge of the debrider when you...
Yes, all the time.
All the time it is in under vision. So you don't
see this?
Any blunders.
See this? All laterally hypertrophic adenoids. Keeping my cutting edge all the time.
So anything specific you're using for irrigation, or it's just normal saline?
Normal saline. Normal saline or ringer lactate.
Okay.
Madhuri, this aspect.
See this? Can you see the lateral muscle? Can you see the lateral muscle?
Yes.
That lateral muscle is the...
Hello, Dr. Devinder.
Yeah.
See, when you have the visualization with the endoscope, per orally also, you visualize these areas. And the area which Satish is at the moment working on is very well seen with the coagulator. And the advantage is that the bleeding doesn't take place because you are after there.
Sir, agreed. Agreed. The problem with the coagulator is you end up charring the surrounding surface. If I use the coagulator in the fossa of Rosenmuller, I will end up charring the torus tuberis, the posterior muscle, lateral muscle, and that will completely obliterate the torus, the fossa of Rosenmuller. Because that charring is inevitable. That is inevitable once you use the coagulator. You cannot prevent.
Because my experience is different, but I am quite sure that your experience is absolutely valid also. I'm not denying that. But I mean, I've been able to remove the way you are removing all the adenoid tissue, and without the real charring taking. I mentioned about my cases of rhinolalia, of course, there, but no bleeding. So
and see, more than that, what you need to see all the time. What you need to see, I am coming to your point, sir. What you need to see is the soft adenoid tissue. See, the muscle will not fall easily into the blade. It is the soft adenoid tissue which is going to fall, and you can see at the end of the surgery, in the depth, the entire adenoid jumped inside the blade and only the musculature remaining. And this little bit of the bleeding is, once you are using the debrider, it is inevitable, and how you can easily control in no time. I will show you.
So you're talking about the muscle laterally, the the rectus cap.
See why we are, paying the price of this little bit of the bleeding is to preserve the musculature. That's it. 20 to 30 ml of the bleeding is acceptable in such surgery using the micro debrider This is under magnification. It looks more, but it is never beyond 20 to 30 ml. And believe me, this gives the children amazing post-op because there is no charring, no sloughing. The recovery is fast. The surrounding musculature is preserved. The long-term, the stenosis, scarring, all these things can be almost certainly prevented. That is the goal. That's why we are not using the cobbletter. Cobbletter is fascinating. It looks so good, then everything comes, bloodless. But the other aspect we need to keep in mind that the charring. That is,
Satish.
yes.
Satish, one place where I use the cobbletter in the beginning is
Yes,
when
ma'am.
children who are just 1.5-year-old who have obstructive sleep apnea.
Yes.
Where you need to remove the adenoids. And of
Yes.
course, the amount of blood loss that they can tolerate is very little.
Yes, yes.
Therefore, in the initial thing, when there's a lot of gross adenoid, that instead of using a debrider, I use a cobbletter,
Yes.
shrink it, and to remove it so that that part of bleeding is taken care of.
Yes. Yeah. That is a great idea. As long as you don't go right onto the perimysium.
And then when you have the residual adenoid, then I start using the blade so that you can skim off the rest.
Yeah.
And then at particular points, you may need to use the cobbletter just to stop the bleeding.
Yeah,
But
that is great. That is great.
remove within cobbletter in very young children.
So sir, below 3 years of age, will we use debrider or I did not get it, sir?
See what madam is saying, during the initial phase of debulking, in young children, even you want to avoid that little bit of the bleeding, right? Going up to the perimysium, you can avoid that bleeding by means of using the cobbletter, and then you don't go right up to the perimysium to damage it, but close to the perimysium and then take over by the cobbletter, by the debrider. That is a good move. You can try. That is something really good. You can see my fossa Rosenmuller now completely. Can you?
Yes, very well seen. Very well seen.
See, the issue is nowhere charring. That is something my goal.
Satish.
Yes, sir.
A lot of juniors, they are worried about using the debrider behind in that fossa of Rosenmuller. So at this time, it's a good idea to explain the carotid anatomy. Also, there are reports in the literature which report injury to the carotid, especially in children where the carotids are really very narrow. Occasionally, I'm not talking of.
Okay. It's a good point. It's a good point.
Carotid anatomy.
I will definitely explain it to shatter the fear of the carotid here.
Yeah, and shatter the fear of using the debrider in that area.
Yes. See, the principle of using the debrider is very clear. I told you not to use it blindly, not to force it inside, keeping the cutting edges in view and allowing the tissue to fall into it rather than poking the debrider deep. That is the first principle. Secondly, about the carotid. I mentioned several times, if you remember, during the endoscopic dissection as well. The carotid artery, see, let me show you where is the carotid, what is the structures behind. This is the longissimus capitis muscle behind. This is a thick muscle, almost a centimeter thick. Behind that is the atlanto-occipital membrane and the arch of the atlas, anterior arch of the atlas. And this approach is a common skull-base approach to the foramen magnum. That is a transodontoid approach, because behind the arch is the odontoid process. You drill away and then go to the foramen magnum from anteriorly. At the level of the arch of the atlas is the carotid laterally. Imagine what I'm trying to say. The carotid is 1 centimeter behind, besides laterally, 1 centimeter behind the plane of the surface of the adenoid tissue. From where my dissection is, the carotid is exactly 10 millimeter behind and lateral. Now, how much lateral? This is the fossa of Rosenmuller, which, I am pointing out at the end of this dissection. The fossa of Rosenmuller, see far laterally, the carotid here is covered by 2 thick muscles. Number 1, the first thick muscle, as I said in the midline, is the longissimus capitis, and the other muscle laterally is the rectus capitis anterior. Number 1. Sometimes the pulsation in this region terrifies you. the pulsations are all transmitted pulsations for that matter. It is very, very rare to have carotid medially projected in the nasopharynx. We know lot of publication, lot of hear about the, the tortuosity of the carotid. Let me tell you how this tortuosity is. We have studied so many times in our dissection. The parapharyngeal carotid first below lies in lateral relation of the tonsil. Then it rises up. In lateral relation of the tonsil, majority of the loops, kinking, all coils of the carotid are in region of the tonsil, that is in the lower parapharyngeal space. There could be coiling, kinking, whatever to the carotid that can happen in that region. After crossing the lower parapharyngeal space, the carotid runs towards the carotid foramen, that is the temporal bone. And in order to run towards the foramen, it straightens up to run towards the foramen. And this is the area in the nasopharynx, the upper parapharyngeal space, where the carotid straightens up, because immediately above is the carotid foramen. So all those kinking, loops, all those things are likely to be in the lower parapharyngeal space, not in the upper parapharyngeal space, for that matter, number one. Number two, see, let me show you the muscle. Here, see laterally, that is the peak of the, give me some instrument, curved instrument, suction. See, there is hardly any bleeding, no bleeding at all. Panjal. People have a fear of bleeding in this, lateral space, with a fear of damaging so many vessels, no bleeding. See, far laterally here, here is the, the peak of this, this thing, the fossa of Rosenmuller. The carotid is 1 centimeter behind and lateral to it. Got my point?
Yes, sir.
And this muscle, this lateral muscle is a very thick muscle, is a rectus capitis anterior muscle. This is longissimus capitis, and this more than 1 centimeter thick vasculature separates from the parapharyngeal space. It is not carotid. First is the parapharyngeal space. And in that parapharyngeal space, the thickest area, the thickest thing which separates the carotid is the stylopharyngeal aponeurosis.
Yes,
the thick stylopharyngeal aponeurosis, if you do many times when we do the endoscopic parapharyngeal tumor excision, believe me, it requires a lot of efforts to cut through the parapharyngeal aponeurosis. Stylopharyngeal aponeurosis, there is a thick sheet of aponeurosis that you have to cut through. There is a thick sheet of periosteum of the carotid, particularly before it hits the temporal bone. So this upper parapharyngeal space, paranasopharyngeal space, has a thick layers of structures over the carotid. And it really, even if you want to reach to the carotid from here, it calls for a lot of efforts to reach that area. Okay. All that easy.
Okay, sir.
Adenoids, for that matter, for the adenoids, we are using our debrider. I told you, let me show you. We are using a debrider, that too under vision like this, pressing on the muscle and allowing the, the adenoid to get sucked into the blade. That is such a simple, safe procedure without anything poking far laterally where the carotid can be. I hope it's clear.
Sir, here I have a question. If there are no ear complaints, no eustachian tube obstruction, still you will go so laterally to clear the disease?
So, what you are going to achieve without doing it? Once you are doing adenoidectomy, why you want to, leaving a possibility of coming back to remove the adenoids again? If you do it properly, there is no harm into it, and it gives a complete, complete clearance. See, the adenoid otherwise, in the same way, keep responding to the allergy and infection, keep giving the same symptoms, same problem, and at some point of time will again get hypertrophy. Okay. So in order to avoid the future problems, this is, we call it as a comprehensive adenoidectomy. See this under vision. This is on the opposite side.
Okay. So Satish, all those complications and calamities you mentioned can happen if you are using a reverse cutting blade of the microdebrider.
Yeah, because then you don't have a control over the cutting edges.
Then you
that's why
all the layers. Yes.
So that's why we always condemn a so-called adenoid blade which is produced by the Medtronic. Use it. I am going to show you in the next case when we are very soon we are going to take a revision phase. and I will show you the utility of that so-called adenoid blade.
So what
Call it
about...
as a skull-based blade.
Yes, sir. So few surgeons have this queries on the submucosal cleft palate. What precautions will you take, sir, for these patients?
Yes. See some of the vessels, small.
Hmm.
Submucosal cleft palate is a cleft palate.
Hmm.
It's a pure cleft palate, and it has to be treated like any other cleft palate for that matter. And once you are treating with any otology pathology in a cleft palate patient, you have to be careful, because all these patients may have a eustachian tube malfunction, because the muscles which regulate the palate or the eustachian tube may be not very developed because of the cleft, and then that may have an impact on the outcome of otology surgery what you do. That's why you have to be careful in all patients having cleft palate when you are contemplating any otology surgery, keeping the eustachian tube function in mind. See now, see the lateral muscle. Can you see very clear?
Oh, yes.
See my cutting edge with me. I am not poking in anywhere. That is something at lower speed, under vision, and you can certainly clear the fossa Rosenmuller completely. And this is what is expected from a comprehensive adenoid. I don't care about this little bit of the bleeding. I told you earlier. I've shown you on the other side. This is bound to stop in no time.
So Dr. Jeevan Vedi has a query here. What will you do if there is enlarged tubal and lingual tonsils?
So this is tubal tonsil only, what we are removing. See, this Walder ring has many components. What we removed in the midline was the nasopharyngeal tonsil, that we call it as an adenoid. Then laterally in relation to the tube are the tubal tonsil. Then below, relation to the palate are the palatine tonsil. Then relation to the tongue are lingual tonsil on the base tongue. So these are the terminology that is a part of the Walder's ring, and Walder's ring has an impact on has an immunological impact in the children, combating the frequent upper respiratory pathologies. So the goal is, see now, once I settle this oozing here, my goal will be complete. What I am going to achieve after this? First of all, comprehensive clearance of the adenoids to prevent the situation of so-called recurrence, number one. Number two, preservation of all surrounding structures. See my eustachian tube orifices on both sides.
Yes.
Pretty untouched, without any damage to the torus or anything.
Yes, yes.
And secondly, see the perimysium. Stand out perimysium all the way.
Bulging. No.
Bright. As long as your perimysium is intact, your musculature is 100% safe behind. Now, I've been using the cobbletter and tried to remove adenoids. I had two options. One is to remove the adenoids from the surface without going to the perimysium, so as not to damage the perimysium, leaving some adenoid tissue, or to go in the perimysial plane, inevitably charring the muscle behind. That certainly those things can be avoided. See, this kind of perimysium achieved by any other thing than the microdevice. That's why this technique, you may face some difficulty of controlling a little bit of the oozing. Believe me, our junior most guy in our hospital is doing this adenoid surgery with the same efficacy, without any problem. So it requires for little extra time, number one. It requires for little extra safety, and that is what expected from a surgeon, to give a long-lasting, morbidity-free outcome to the patient. See now the perimysium, amazingly standing out perimysium, and see this is planned charring, coagulation of the periosteum, which I don't want. That is the site of bleeding. Muscles contract, periosteum do not. And that is the source of bleeding in those patients.
Yes, sir.
My coblation was used intermittently, you have seen, for the oozing. See the fossa of Rosenmuller now? Completely opened up. This minimal bleeding will take care. And this warm saline has a huge impact. We have done through this technique thousands of the adenoids. See the fossa of Rosenmuller for everybody.
Yes.
Can you see anywhere any residual adenoid tissue now?
Absolutely clean. Satish, absolutely clean.
No fear of bleeding. Where is the huge bleeding?
Satish.
Yes, sir. Yes.
Satish, in an adult patient, if you have a nasopharyngeal mass, okay, just a quick word on it. How will you clinically diagnose what it is and radiologically? I mean, just some features for the youngsters.
Adult with a nasopharyngeal mass.
Yeah.
My MRI will differentiate what it is, Narayan.
Yeah, exactly. Just enumerate it for the juniors.
So MRI with a diffusion weighted sequence will clearly distinguish what kind of mass it is, whether it is benign or malignant, because many of the nasopharyngeal masses are lymphomas, which I can almost always pick up with a diffusion weighted MRI only. Lymphomas are most cellular tissues, most cellular. Out of any tumor in the body, out of all tumors in the body, lymphomas are most cellular, and they show the highest level of restriction of diffusion on MRI, and you can pick up solitary. The lymphoma is very, very clear. And then you don't have to, once you know could be lymphoma, you are not supposed to do any radical surgery. Your goal is to take a biopsy, get immunohistochemistry done, and then direct the medical therapy over it. So the imaging has a big role. Now see the final picture. Can you see?
Yes, yes, Satish. Very good.
See my goal of adenoidectomy. Both sides, torus intact, completely eustachian tube intact. This is my soft palate, completely preserved. This is my perimysium, completely preserved. This is the periosteum is coblated, and these are the fossa of Rosenmuller, which are completely cleared off. And without giving any charring to the muscular area, I don't expect any sort of nasal twang or any sort of, stenosis, any sort of infection, any sort of too much of what you call that as, slough and anything is not expected from these children. So a right technique is required to prevent all these issues. And see, we all are striving for the betterment, and this is one of the propositions from our side. And this is our, time-tested technique, which we have been doing for years together to prevent problems in these children. You can just do it, send these children back home in the evening, and forget about anything. What we do post-operatively, that is our set protocol, because we are all, concerned with the allergy and the inflammation. Post-operatively, we get a complete allergy workup done. We get a complete immunology workup done, as many of these children are immunocompromised, which go undetected, and then completely follow that treatment. And as far as the medical treatment is concerned for long term, we give them mometazone nasal spray and Montelukast. Montelukast has turned out to be a major drug for the lymphoid hypertrophy. It has been proven by the literature, even by the meta-analysis now. Now I'm, irrigating the nasal cavity.
So,
see, there is no trauma, hardly any trauma. Yes.
Satish, I just ask you about if there's a infant, let's say 1 year or less, would you be adopting the same technique, number one? Yeah. And would you be adopting the same technique even below 1 year of age?
Yeah, see, little different in the sense, in below 1 year, the only indication is obstruction. There is no other indication to do an adenoidectomy in a child below 1 year.
Exactly. I'm talking, there is an indication of obstructive lesion, and we have operated many kids below the age of 1 year.
Yes, yeah.
So that's why I'm asking that question.
In that situation, yes, you can avoid the lateral, adenoids in a 1 year below child, except that everything is same. Right. Everything in the lateral component can be avoided, because in below 1 year conceived obstruction which you can obviously accomplish by the midline removal of the adenoids rather than doing laterally hypertrophic and giving more operating time, more morbidity, more blood loss to those children below 1 year. So you can stay in the midline for those children. The rest is same.
Would you like to then to use a coablator for such children, or would you like only this, or have you used a coablator in
Yes, yes.
infants?
Yes, yes. Coablator, very well. See, this use of micro debrider in those children, the 10 to 15 second use of micro debrider and packing, that's it. That doesn't lead to more than 5 ml of bleeding. Believe me, the only once use, but it, it gives you a confidence, it gives you a security that you have not damaged anything behind, because that is our concern.
I agree, but I'm just talking about now the people who are infants. I'm just talking about a particular set of people. And
Yes.
second, I'll ask about the second set of people is the Down syndrome. Would you be using the same technique?
Which syndrome?
The Down syndrome.
Yes, yes. Those children, we don't go so extensively.
Because in a coablator, you can be extensive.
Yes,
That's the
yes.
reason I'm
With
asking.
coablator, because Down syndrome has many implications as far as the adenoid is concerned. The anatomy is concerned.
Yes.
There could be aberration in the anatomy of the carotid artery, could be aberration in the anatomy of everything around. So you have to be very cautious, you have to be limited, because the goal is to just give airway and then follow with the medical treatment rather than going so extensive.
Because with the coablator, you can go more extensive with a better removal. So just wanted to put a point in view, nothing beyond
Yes,
that.
yes, sir. Yes, sir.
Excellent. I mean, I'm amazed at the way you operate, and it's an excellent presentation, of course.
Thank you, sir. Our next case is ready. That is
Sir,
a microlaryngeal surgery with a laser. Yes, yes, Paramita, we can carry on to the question.
sir, is there any adverse effect on immunity of patients after adenotonsillectomy? Dr. Sudeep from Jodhpur is asking.
Yes, that is a very important concern, and that used to be a big, question from the attendants as well. That this is a part of the immune system, and it can have an impact on the immunity once you remove this part of the immune system. See, this is not only the immune system in the child. This is just part of the Waldorf's ring. And the adenoids normally, which do not give rise to any problem, are not need to be removed. Only those adenoids which are harboring biofilms, giving problems, giving immunological problems, giving obstruction, giving sinusitis, giving ear problems, those need to be addressed, which are actually not serving their own purpose, and that's why they need to be knocked off. Adenoids harboring biofilms, adenoid harboring so much of immunoglobulin E or something are giving problems and need to be removed. In normal function, adenoids synthesize immunoglobulin A. Almost 15% of our total body immunoglobulin A is secreted by the adenoid tissue only, because 60% of the adenoid is B lymphocytes, But once they are affected by the inflammation and the allergy and that hypertrophic involved in the infection, they no longer serve their purpose. So we have to convince them. Many times the patient relative come and ask this question up front. You have to counsel them. आपका चौकीदारी चोरी करेगा तो क्या करोगे? This is something like that. See, you have to knock them off once they are not serving any purpose and rather creating problems. And there are many, immunogenic tissues in the body to take over that function rather than adenoids only.
Okay. So many were actually requesting to have an external view of the endoscope and the debrider that you've been using. So maybe.
Satish, good morning.
Yes.
Good morning, Satish.
Yes.
Yeah. See, in my experience, I have seen when conventionally they done adenoidectomy, damage the station tuberosities area, and that would have caused cyanosis and synechiae. And that permanently damages the station tuberosities, and then they'll have a lot of ear problem for lifetime. So,
yes,
in such situation, do you have any solution for this once you get such case?
That is, your concern is very important, and because of that concerns, I am not using anything carrying this problem. Believe me, if anybody going in the fossa Rosenmuller with the cobbletter and try to remove the adenoid extensively, completely till the muscle surface, it will end up giving, you know, I would say extensive fibrosis, irreversible fibrosis once it heals up, and that is something difficult to treat. That's why, for that reason only, they are using the debrider and, you know, paying the price of this extra little bit of the bleeding to prevent that complication. Now there is no scarring. The healing is so amazing. With everywhere the perimysium is intact, muscle is not damaged at all, and there is no question that kind of fibrosis or stenosis.
Yeah, now what you did is excellent. Suppose if you get a case where it has been done by a surgeon by conventional technique and it has been damaged, do you have any answer for that?
Yes, if you have happened to damage that area, what you can leave for the time being, you can leave a piece of silastic and pack for some time, and then you can come back and remove and give lot of irrigations in the post period to prevent that stenosis, to minimize that. You cannot prevent that, but you can try to minimize by doing all these things. But I'm not sure how they are going to help it or not. But this is something we have never done.
Okay. Satish.
Yes, sir.
Satish.
Yes, ma'am.
So we've done a study once where we first did a blind curettage of the adenoids till the surgeon felt that he'd done a complete job, and then we used an endoscope to see what is residual adenoid tissue was remaining behind and as to whether there was any damage to the eustachian tube. And what we found was that we didn't find a single case of damage to the eustachian tube because the surgeons tend to remain away from the lateral and stay only in the midline. And therefore, always there is tubal tonsil remaining behind. And right at the very apex of the nasopharynx, close to the posterior end of the septum, is where the tissue remains behind, because the curette doesn't have an angulation which reaches almost up to the posterior end of the septum.
No blind instrumentation can achieve this kind of clearance.
Yes, and therefore the two main areas we found were the tubal tonsil and very close to the posterior end of the nasal septum on the absolute roof of the nasopharynx.
Yes, madam. Agreed. Absolutely.
Sorry, Satish, because a study has just been quoted. We'll quote our thesis study also.
Yes, sir.
We compared microdebrider versus the cobbletter, right? And we did a post-operative flexible laryngoscopy. That's a nasal examination, seeing for the fibrosis, especially and all that. None of the patient had a fibrosis as far as coblation concerned. On the other hand, I did not use the same technique as you using. We were doing the adenoidectomy as such. Some of the tissue was left with the microdebrider because during the surgery, somehow this is what and I'm rightly so. That's the reason why we left doing that adenoidectomy with the adenoidectomy blade as such. We provided the Medtronic because somehow or the other we used to enter into the paramecium. The bleeding used to be far more. And we found the cobbletter far a better technique than the technique that we were using. Your technique is very good, there is no doubt. But I think the cobbletter still has a good place if a person learns it well.
Cobbletter is amazing tool. See, if you find anywhere some excessive bleeding or anything excessive wounding anywhere in the field, you can immediately use cobbletter. Such an amazing tool. I've been using cobbletter in a skull base like anything as a main tool.
I know you've used it extensively.
Cobbletter is amazing, but here once it comes to function preservation in these children, we are little scared about fibrosis. That's why we are giving preference to the microdebrider. On the other hand, these are different advantages and disadvantages. We cannot compare them. It is like comparing apple with the orange. These are different tools at all.
Right.
Cobbletter has a different ability. Microdebrider has a different ability. We can't compare them. Both are so useful. Only thing is in our practice, how we can get best of the results by optimum use of both of these tools. Both are equally good. Both are amazing. I am not saying any tool is bad. We have to decide ourselves where can be used, what tool can be used where, and with the optimum results.
Sir, there are few surgeons who also want to know the preference of Dr. Kirtane, sir. So there have been few questions. So what is your preference, sir, on this?
Sir.
No, we
Kirtane, sir.
like what Satish has shown. We use the micro debrider with a 60 rad blade. The only difference is I do it per orally. We put catheters, just lift up the palate and use a 70-degree scope through the mouth. So I don't have to go through the nose and worry about damaging the nasal mucosa or synechia. And I think even there, as Devinder said rightly, the tip of the blade can remain under vision without any problem. Satish, just one quick question. Can you tell me what are the next two cases that you're going to do? So I'll tell the people.
Sure. So our next case is going to be a microlaryngeal surgery, a benign lesion, benign nodule, and then would be a revision fest.
Okay. And after that, you'll start with the parapharyngeal tumor?
Pardon? Yes. After that would be a parapharyngeal tumor.
Okay, fine. So I'll inform the concerned people accordingly that Dr. Devendra Chaukar can come in at that time.
Yes, sir.
Sir, how long will you prescribe Montelukast post-operatively?
Yeah, Montelukast at least for few months, because meantime we work up for the allergy and the immunity.
Okay.
Many children who have a history of repeated, infections, we get the immunoglobulin levels done, and many times we found issues in the immunoglobulin levels as well. So allergy, many times adenoids are associated with the house dust allergy, They have a family history of allergy, and you will find if you elucidate the family history of the children, many a time you'll find a clear-cut association of allergy in the parents, and that is how the adenoids are, given in the children because of the allergy which is transmitted.
Okay.
So allergy, yes. So we are all set for the third case. Paramita,
Yes,
you
sir. No, sir. I just wanted to tell to the viewers that the ones who have joined late, the talk on the scope and the type of blade has already been described, and many more questions that they've asked has already been described. So I think we'll move ahead with the next case, and the ones who have missed, they can again watch the video later. Yes, sir. We can move on to the next case.
Yeah, it will be available on YouTube.
Yes.
Regarding the laryngoscope, there are a variety of laryngoscopes, needed in different situations. We have almost 16 variety of scopes. And this I learned from Nupur, who has even more. In what situation, what kind of laryngoscope, the advantage, disadvantage. Is Nupur online?
Hi, Satish.
Hi,
I think
Nupur.
having an array of ML scopes is great, but for people who are starting out, there are two laryngoscopes I would suggest. One is the regular Klein-Sasser laryngoscope, medium size, because our Indian population doesn't really need a large size even for the adults, and a small size. And the other is a Dido laryngoscope, which I find has saved me in a lot of difficult situations. That's a Storz scope. I'm not trying to market for anybody at all, but it's a scope which has really helped me out in many occasions. So to begin with, I would say these two scopes are great to have, small and medium size.
Yes. So last time in microlaryngoscopy, we showed a T1 vocal cord cancer and did a cordectomy, type 4 cordectomy with removal of the muscle, part of the muscle. We have now in the coming webinars, we'll be having a variety of laryngeal situation, type, the grade 2, grade 3, grade 4 cancers with different approaches. This time here is a very simple situation, very common, which sir had asked me to keep, which is very, very useful in our regular practice, is a benign nodule. Are you getting the picture?
Very clear.
Yes.
Very clear?
Yes.
So, this is a benign laryngeal nodule in a person who is not actually a professional voice user, but he had, when I elucidated, had a history of voice abuse. This is not a classical nodule which you will see in a patient with a voice abuse. Nupur.
Satish, if I may suggest, we should not use the word nodule when we see this kind of
Yeah, this is not nodule actually. Yes, exactly.
Because, the classification of benign lesions has been made quite nicely. Nodules should always be the typical bilateral at the striking zone. So benign lesion at the striking zone, or a vascular lesion at the striking zone. Because when we say nodule, most of us think of typical nodules.
Yes, yes, exactly.
You have a feeding vessel for this lesion coming from anteriorly.
Yes.
Many surgeons would make comments that they would like to do subepithelial infiltration and do a laser fulguration of that feeding vessel to decrease the chances of recurrence. What are your thoughts on that, Satish?
Yes, yes. That is something, one way. And Nupur, since we have to show various techniques and variety of situations, this nodule, this lesion, my question to you is, would you go with a cold steel or with a laser, and why?
That is exactly what
I am going to show with a laser here,
right.
for that matter.
I think vocal outcome measures would be equal in the, it depends on the surgeon's hands and capabilities, etc. But one can achieve fantastic results with cold steel as well as laser, as long as you have a good quality laser, as long as you follow the phonosurgical techniques of infiltration, elevation, staying superficial. The only issue is,
and I am not going to do anything.
The only issue is the feeding vessel. A laser would have the advantage of being able to just, what we say, laser fulgurate it at 1 or 2, like spot welding kind of thing at 1 or 2 spots, so that the feeding vessel is also taken care of.
Yes, agreed. So now we'll have variety of benign lesions and we'll be showing it differently. Here I am showing in the most, raw way, without infiltrating, without doing anything, with a simple laser, with the principle of minimal wattage of laser. I will tell you the advantage. I can use a high wattage, high depth of the laser, but here I am going to use the minimal wattage with a minimal length. The reason is, I am going to stick to the superficial lamina propria. Can you see that, B?
Yes, sir.
Yes.
See, this lamina propria has 3 layers. See the most lateral, the superficial epithelium, then is the superficial lamina propria, then is the intermediate lamina propria, and the deeper lamina propria and the muscle. So here I am going to stay very, very superficial. See the minimal watt. Why I am saying minimal wattage, and not to damage anything underneath. I am retracting immediately. This is the simplest of the benign vocal situation, or I would say lesion situation, you can think of. Pulling more and more medially, and this is the minimal wattage with the depth 1 I have kept. You can see.
So you're using an Acu pulse, are you not?
Yes.
Right. So, so are you at 10 watts, Satish? You're using a scanning system or a non-scanning?
Yeah, scanner.
So with the scanning system, you're using, ideally we use, so just want to clarify here that when we have a scanning system, typically we don't use a low wattage. We have to work with the fluence of the system. The fluence is the wattage, the depth of the penetration, the time on and the time off. These 3 parameters give us the fluence. And because a scanning beam is scanning a surface, we don't have to use a minimum wattage of 1 or 2. We work with 10 watts because it's
minimal is 10 watts here once you do the super pulse.
Excellent. And you're using 1 depth, which is not 1 mm, but 250 micrometers.
Yes.
And probably your speed on and speed off may be 0.03 and 0.3. I don't know.
0.3.
Yes. So wonderful, not a dot of char. What a wonderful job you've done. We've got a completely straight vocal fold. There is no charring whatsoever, and very efficiently performed surgery.
See, what I wanted to show here is,
excellent.
What I wanted to share is, by pulling it medially, I didn't inject any saline or anything. I just tried to stay in the superficial lamina propria. And that is something which is the least chance of giving any kind of scarring. If I go in the depth of the lamina propria, I may leave some scarring, My goal, because I told you this was the simplest of the lesion one can think of. And in such patient, you can expect a very good voice immediately after the surgery as well, because I just went through the superficial layer of the lamina propria. Can you see, Nupur?
Yes, fantastic. You've shown very important points, that you stay superficial, that you do a surgery which is totally char-free, so there's no heat dissipation. Patient will do excellently. I don't know whether you believe in voice rest or not, but this patient will do excellently. And you'll probably want to give some voice therapy so that there is no recurrence because of vocal abuse and misuse pattern.
See, the beauty of the laser is, and particularly with this scanner system from Luminous, you can target the lesion the way you want. Had I been doing some, chordectomy like you saw last time, I was using a continuous, power with a power of 14 and was a continuous laser, and I could go all around the lesion. That was a different pathology, different aim, everything different. Here the aim is preservation of voice. The sole aim is preservation of the voice. More you traumatize the vocal cord fold, vocal cord layers, vocal fold, worse the results you are going to have. So my goal was just to stay in the superficial lamina propria and get away from this. That's it. I could do with the cold steel as well with the similar results. What do you say? Any difference in outcome with the cold steel with such a lesion, such a superficial lesion?
I do not think so. Just the feeding vessel, one may or may not want
that
to
would trouble.
visualize,
That could trouble. That could trouble.
But I don't think there would be any difference whether it was cold steel or laser. One can have equally good results.
Yes. So this was.
So there's a. I want to ask the panelists and to you especially that what precaution will you take now during this COVID pandemic situation while doing these airway surgeries? Nupur ma'am.
Same. Yeah, a lot of people are recommending respirator. There are many ways. We are just using level 2 PPE, not respirator. For that matter, we have a suction evacuator attached to the laser at the same time to prevent the fumes coming out. That is the only thing we are doing. Otherwise, nothing else.
Ideally, one should use a PAD air purifying respirator. I really think Satish also should.
Yeah, you sent me that picture, Nupur, I remember.
So there are two varieties. One is you get a type where you have a helmet with the HEPA filter on the helmet itself, and the other is where you've got the HEPA filter on your waist. So you can choose whichever type you want. We have all varieties, and the reason is because we as ENT surgeons and especially airway work and laryngology are directly in the line of fire, so to say. So not only is it very safe for you, but also you are not experiencing hypoxia of any type. Now, someone like Satish who's operating from morning to night, he obviously cannot be wearing an N95 and surgical mask and operating. But if he wears a PAPR,
I am wearing N95 and surgical mask.
but with a PAPR, Satish, one would be so much more comfortable because it's positive air. Simply for that
I agree.
So
agree with
I
you.
encourage you all to do that. The advantage with the PAPR on the waist is that people can share it because the hood is disposable. It's a 500 rupee hood which you just throw. So you can have colleagues sharing it also. So, there's a company in Bangalore which makes it, and the other one is in Bombay. Anyone interested can email me.
Nupur, can I ask a question?
Satish, congratulations. Sure.
Thank you. Last
Super
time.
job is what I wanted to say.
Thank you. In the last LChem, conclave last year, Nupur had demonstrated some phenomenal surgeries from Bombay Hospital. And Madhuri Madam demonstrated from, I remember, from Hisar. And you demonstrated one micro flap as well.
Yes.
If you remember.
Yes, I do.
My question is for the audience, when do you recommend a micro flap technique in benign lesions of the vocal cord? Maybe a nodule, maybe a cyst, or maybe other benign lesion. Whatever you classify.
So you can call any lesion which is epithelial. Obviously, you would be taking the epithelium off. So even though papilloma is a benign condition, we are not talking about that. Nodules I've hardly ever operated on because I feel they all respond well to therapy. But polyps and cysts especially lend themselves beautifully to microflap because they lie underneath the epithelium. They may or may not be attached to the ligament, but they lie in the SLP and they lend themselves beautifully to microflap, classical microflap. In polyp surgery, Satish, what we are doing is we create a microflap But we've realized that the larger the polyp, the more the redundant epithelium. You don't have to
Yes,
bother
you
to
can't keep.
save it all.
Yes.
So only you have to save the infra, like you did a polypoidal lesion right now. One only has to make the effort to save what we call the infraglottic epithelium, barely 1 to 2 millimeter. You know what is lying on the undersurface. If you just save that, it drapes beautifully on the raw edge, so you get a zero raw edge. So that is more important. So we do microflap in sort of, you know, modifications of it. So you're just trying to make the raw area less.
Okay, ma'am.
Secondly,
Satish, can I
secondly,
just add to that?
yes, please.
Yeah, just when we talk about microflap, essentially we mean that microflap dissection, not microflap reposition always, as we have earlier thought. You know, in early 80s and 90s, people thought microflap is synonymous with elevating a flap and putting the flap back completely, like Nupur said. But now microflap means that if you think the lesion is deeper and if you're going to be working in the superficial pinky space, then you want to dissect it as far as possible, and then whatever redundant mucosa is there, you remove it or you can reposit. So not always, it is the dissection which is microflap, it is not the reposition which is microflap always.
Ma'am, I will come back to you again about the voice rest. As you said, after surgery, for how long will you give and how beneficial it is, ma'am, in this surgery especially?
Paramita, before
yes,
that,
sir. Yes, sir.
define the vocal rest, Nupur.
Yes.
Yes.
Voice rest.
I'm
Yes,
just
sir.
coming to, there is a dichotomy in opinion to begin with, whether you want to give any vocal rest or you're not. There's some surgeons who believe in giving zero voice rest, some surgeons who believe in giving voice rest. In voice rest, you can have a complete voice rest, or you can have a patient talk in what is known as a confidential voice. Confidential voice is you're talking one-on-one. There's one person sitting, which is not a whispered voice or a breathy voice. A lot of research which has been done actually shows that the maximum amount of healing which has to take place starts actually after within 24 to 48 hours. Okay, and they have done research papers where they've shown one arm which took voice rest and one arm which did not take voice rest. And these papers, some of these papers have shown that it didn't really make much of a difference. So I think it's totally on the surgeon to decide whether they want to give voice rest at all or not, because there are enough papers which show the vocal outcomes are the same. I personally like to give voice rest to each and every patient of mine, and I have specific reasons why, and I give it for 7 days. But I tell them for the first 5 days, I want you on complete voice rest. After 5 days, you will start on confidential voice. Start talking 10 to 15 minutes per hour, and every day you double it. So 10 to 15 minutes an hour on the 7th day, 8th day will become 20 to 25 minutes, keep doubling. Why do I believe in voice rest? Because I feel Indians talk too much and they talk too loud. And you know, this is like a cultural thing, you know, and I feel that the way we talk, the speed the Indians talk is very fast, the volume we talk, and we are a talkative race. So I feel the amount of understanding also, when we say to patients, they may say, we will talk 5 minutes, but they will talk 50 minutes. So in my group of patients, and I feel Indian patients in general, better to tell them voice rest. By default, they're going to be talking a little anyway. That's my take on it. Satish and Amitabh, I would love to know your take on it.
Yes.
I think for me, it is just slightly different. Only instead of 5 days, it's 72 hours, 3 days absolute voice rest. And rest of the things are all fine. But it is also important to customize the voice usage depending on the patient, because a person who is going to sell fruits in the market will have a different kind of a voice rest, and compared to a person who would be working in a environment where he's doing board meeting all the time with microphone on. So that is the only thing I would consider, that to customize. But first 3 days for me, absolute voice rest, the epithelium to heal and not to have any hemorrhage and that because of strain, and then gradually take it over depending on the plan. We call it planned returning to voice. That's the term that we use depending on their profession.
Dr. Yogesh from Erode is asking what size of endotracheal tube are used for microlaryngeal surgeries? Is there any specific that you would like to say, ma'am? Sir?
Typically 5 and 5.5. I mean, 5 for the female adult, 5.5 for the male adult. Of course, in children, you will go 3.5, depending on what is the age of the child.
For the
And
last
these are
case,
with
what
a
I
larger
used was
cuff.
a laser tube.
Okay. Sorry, sir.
The last case, what I used was a laser tube. It was
Okay.
5.5.
Okay.
And this laser tube has two, bulbs to inflate.
Hmm.
One containing methylene blue and one saline. And this
Okay.
is what the advantage of the laser tube to prevent a laser fire in case the laser by mistake fires at the bulb. Still you can appreciate as the first bulb ruptures.
Hmm.
That is the advantage. Nupur, before we move on to the next case,
Yes.
any tips to deal with the scarring,
Yes, to prevent scarring is more
No,
important.
if the
than
scarring has happened to occur.
Okay, so if the scarring, you catch it early on, then injection of steroids into the superficial lamina propria and even injection of hyaluronic acid may help because there is some amount of growth factor also in it. So a combination of hyaluronic acid and steroid into the SLP area after 3 to 4 weeks when you catch the early scarring. You can even do 4 to 5 repeated injections of this in a prevention of. If it is very long term, then of course you're talking about like a scar or sulcus which has formed, then growth factor injections, which are not always available, but they are available in certain situations. Injections of growth factor into the superficial lamina propria have been described. You can also do things like fat implantation, small pieces of fat, you chop them up, or fat injection into the SLP. So these are options for scarring, early and late.
Okay, that's great. And I think it is a very, very difficult problem to treat for anybody.
Yes.
And it requires some repeated efforts.
Yeah, prevention is always
the best thing.
better.
Thank you, Nupur. Thank you.
So much, Satish. Wonderful being with you.
Thank you.
Thank you, ma'am. Thank you so much.
Thank you, Paramita. Thank you to Dr. Kirtane.
Always a learning experience when you interact with Nupur, and it is something amazing. Thank you.
Thank you. I would like to thank Sir and Alchem. Thank you.
So now we move on to the next case. And are you getting
Thank you, Nupur. Thank you very much.
Are you getting something on the screen?
Yes, we've got the CT picture there.
Okay. So this patient has undergone sinus surgery somewhere a year back and now presented with a full-blown disease. And you can imagine what kind of the work was done. It was something like a polypectomy or a little more onto that. Nothing much. For sinus surgery, when we discuss, so this is for revision. The most important thing is the planning. Planning from diagnostic point of view, not only the scan gives you a roadmap, but other planning to go into the, the pathophysiology of the disease. Like we discussed in the first webinar, you need to get certain tests done to find out the particular endotype of the sinusitis. If you find the particular endotype and follow it, then only you can expect a good result, because this is a medical disease for which the medical treatment is the treatment. Surgery has a role to facilitate the medical treatment most of the time. Like many of the patients, we have shown the allergic fungal rhinosinusitis. It has a different endotype because the patient has a allergic to the fungal antigen. AERD is a different endotype where the patient has a fault in the, the arachnoid acid metabolism, where a lot of leukotrienes forming. So there are a lot of endotypes, and you have to actually go into the pathophysiology to get good outcomes. And when it comes to surgery, today here we are going to discuss the surgical aspect. The most important thing is the surgical planning, and for which the radiology is most important. And the simplest radiology what we need is a non-contrast CT scan. CT scan gives you a path like Google Map, believe me, provided you have an adequate and optimum radiological investigation done. So we always recommend, or whenever we order a radiology, to get the entire data in a DVD in DICOM format to get complete three-dimensional dynamic information. And this is what the need of the time. The reason is, when patient bring you some films, like 1, 2 or 3 plates having 15 to 20 slices, almost 50 to 60 slices is too inadequate an information. Here in this particular patient, if you see the 0.7 mm scans done, this area of the paranasal sinuses when you scan is almost 20 centimeter or even more. 20 centimeter means 200 millimeters. How many slices you need? For that matter, in this particular patient, even scanned even a bigger area, and you know, in the axial section, these are always shot in axial plane. See, in the axial 423 slices. Imagine how much the data it has been having. Number one, to give us complete information. Secondly, we need this information in all planes. Now with the DICOM format data, we can easily reconstruct through our software. See, now I can reconstruct in 3 planes like axial, coronal, sagittal, and you can see every structure 3-dimensionally in each plane. And that is an amazing tool to have in your mind the 3D picture of the anatomy of the particular patient, about the disease. And this is an amazing teaching tool as well to teach the colleagues that how to read a CT scan as well in all planes. So this dynamic information cannot be achieved with the plates in hand, with the printouts. And number 3, the information in different, window settings. Sometimes you have information in bone window setting, you want details of the soft tissue window. From this software, you can easily change into different window settings. From bone window to soft tissue, this is soft tissue window now. See this, the soft tissues are seen much better than what earlier. Now I can change to the bone window. Now the bone is more prominent and seen better than the soft tissue. You can yourself reconstruct. If you have a printout, you need 400 slices in axial, 400 in coronal, 400 in sagittal, 1200 in bone window, 1200 in soft tissue window, 2400, and to carry those slices, patient will have to carry a huge bag, which is not possible. And that too, not a dynamic information. That too, impossible to read for a surgeon. And that's why the first message is to get the information in DVD, a complete fine section in the axial plane, and then we can reconstruct our own. See the soft tissue window setting. You can see all soft tissue details better, and this is otherwise you don't get in bone window setting. So this is the first thing, what kind of a CT scan is required, and then quickly how to read in dynamic fashion. Earlier we used to follow each and every structure in a static way from one film to another, that this could be the drainage pathway of particular sinus. Let me show you how easily you can see the drainage pathway of any particular sinus in all planes. Let me show you in all planes. For example, the frontal sinus for this particular patient. For this frontal sinus for this particular patient. See, this is the, if I come from anterior to posterior, this is the beak, the nasal bone anteriorly, the beak behind, and see the 2 frontal sinuses with unequal, appearance because of the intersinus septum. Now, how to see the drainage pathway, whether it is medial, lateral, where it is going? You can easily see. Let me show you on the coronal first, then we'll go to the all planes. See this, I am going behind, this is my frontal sinus. Now see this additional septation coming as I go behind. I am going behind. So this is incomplete septa giving rise to this intersinus septal cell. Can you see this very clear? Now we need to know where this intersinus septal cell is opening to. See this intersinus septal cell, and see now this is opening into right sinus. Can you see very clear? You can see it in the dynamic images very clear where it is opening. Now see the drainage pathway of the frontal sinus here. See this frontal sinus, the drainage pathway of the frontal sinus as you go behind, this is frontal recess. This is incomplete septation, and this is your drainage pathway medially. So for every sinus, see this frontal sinus, this is opening in this intersinus septum, is opening in the frontal sinus, and this is the median drainage pathway of this, the right frontal sinus. This is median drainage pathway. Why? This is the agar cell which is going up and inserting onto the, lamina papracia, and this is your middle turbinate, and this is your medial drainage pathway. So about the cellularity, about the drainage pathway, every information you can get in a dynamic fashion when you have a good dynamic, CT scan. Now going back to the soft tissue, see the advantage of soft tissue settings. This is soft tissue window. I'm coming from anterior to posterior. Now the soft tissues are better characterized, Now look into the orbit. What I want to show in dynamic way. We all know we want to see, it may be a requirement, whatever. We every time want to positively identify the course of the internal anterior ethmoidal artery. Best is go to the soft tissue windows. Why? Go to the orbit, because we know the intraorbital course of the anterior ethmoidal artery, where it comes out, is given up by the, I showed in one of the CT angiogram in a JNA case in one of our previous webinars, how to trace the ophthalmic artery, and from ophthalmic how to trace the anterior ethmoidal artery going to the orbitocranial canal. So as it comes out of the orbit, as I go behind, this is medial rectus, this is in soft tissue setting, this is superior oblique, and as I go behind, see this, as these two structures come close to each other, see here, this is the canal, that is the coning of the orbit. As these two structures come together, this is the coning of the orbit from where the anterior ethmoidal artery leaves. This may not be prominent always, but yes, if it is prominent, you have to be careful. You have to give importance to it during surgically, that you are not supposed to damage it, maybe in mesentery sometime. This is the way of finding the artery. That's what I want to say. So anything in the sinuses, you can see dynamically if you have a dynamic scan, and that is what the need of the time, rather than the static picture. I'm not going in the details of the reading the CT scan. These are just few points, but in this particular patient, what I see positive finding is a complete whiteout picture bilaterally, complete whiteout, complete preservation of the whole septation. You can imagine what was done during the previous surgery, you can think of. And then some, I was trying to see if some heterogeneous opacity to see or to pick up if there is any fungus inside. See, this is the way in the soft tissue window setting. If you find some heterogeneous opacities in the sinus, see, these are the sinuses, and I don't see any major heterogeneous opacities signifying any fungal disease. Can you see this? It is not. Otherwise, in a fungus, we have shown earlier the allergic fungal sinusitis and those cases where the lot of heterogeneous opacities signifying the fungal disease. So this you can pick up very well on the soft tissue imaging. Then the deviation of the septum, the turbinates, the situation of all these things are important, because sometimes you have to counsel the patient pre-op that we may have to add on a septoplasty, we may have to do a turbinoplasty. It has its medical legal implication also nowadays when the informed consent is has a value. Then there are some osteitic picture. See this. What I want to show as I go behind, I see some sort of osteitis, patchy osteitis somewhere. Osteitis is something signifying a depot of cytokines. That signifies the huge eosinophilic disease as well, and you have to remove all those septa signifying this osteitis to completely get rid of this, depots of cytokines. Otherwise, the persistence of the inflammation will bring in the disease again, and that is something you need to prevent. We need to see all septations by and large are, protected. Nothing, hardly anything was done during the previous surgery. I can see the turbinates. I can see the pissed off turbinate because of the polypoidal masses. They have been, atrophic, I would say. And then the completely, white out picture everywhere. This is your, the rostrum of the sphenoid looks rheumatized in the center. You have to be careful in these situations, because sometimes you look for the sphenoid and you end up opening a rostrum and avoid the sphenoid opening. We have to be careful. This looks like onodi situation this side, and this is the sphenoid with intersphenoid septation, and this is now this is the optic nerve impression. There is hardly anything significant. The only thing is I can see the little bit of the lateral recess on the left side and complete whiteout. So my goal is to do a complete full house FES. Complete full house FES. I will demonstrate here for the sake of demonstration on one side, and then we'll move on to the other case as we have to finish the other cases as well. The other side will not demonstrate, and one of my colleague will finish off the other side. So one side will discuss in detail the surgical part. See again the orbitocranial canal. Can you see here?
Yes.
The anterethmoidal artery emerging out of here. This is medial rectus superior oblique, and see how the artery is running. The movement where the artery runs out, this is posterior artery. This is posterior artery. The anterethmoidal artery is much anterior. This is here. Can you see both arteries?
Yes, sir.
This is anterethmoidal artery, and as I go behind, this is posterior artery. So the another thing is the moment you see the anterethmoidal artery and go behind, then is your posterior starts. This will confirm endoscopically as well when we operate. Anterethmoidal artery runs through the posterior most part of the roof of the anterethmoid, and behind that immediately is the beginning of the roof of posterior, and this has a immense significance as we walk anteriorly into the frontal sinus. We will see the artery is miles away behind. Once you use a 70-degree up, the artery remains behind in a different trajectory because it passed through the posterior most part of the anterethmoid, and when you use a 70-degree for the frontal, you are more anteriorly inclined, even anterior to the anterethmoid in the frontal sinus. So that kind of fear you can easily remove by means of understanding this anatomical information. So here my goal is to do a full house FES on one side. Any questions before we move on?
Yes, Satish. What is the medical therapy you have given this patient, and what is the timing of your CT scan? When have you done this?
Yes.
Can you throw some light on that?
Yes, yes. That is very important aspect. This patient has been under pre-operative management for last 7 days. We have given him initially 3 days a broad spectrum antibiotic tablet for 3 days. Then we stopped because our focus was on the inflammation, and these are not infective cases. We have been giving him Visolon for last 7 days. We have been giving him the saline irrigation. Earlier, when this patient contacted before coming, we started the doxycycline as well. For some time, doxycycline has a role in polypoidal sinusitis to reduce certain inflammatory markers in the polypoidal disease, not in the polypoidal, not in the non-polypoidal, but in the polypoidal only. And this is what the medical management we did. He is a young patient, 18-year-old, and without any other systemic diseases. So it's a straightforward case. And looking at the massive disease wiped out with the previous surgery done, our goal was to do a complete full house FES, and then we'll follow post-operatively with the steroid irrigations. So here the goal is a full house FES. Now we'll not leave any opportunity which prevents accessing the sinuses post-operatively in your OPD. We'll open a frontal wide opening of all sinuses because this is pure massive eosinophilic disease which requires steroids. And once you remove this disease, that will make the topical steroid penetrating deep into the cavity. That is what we want. So this patient will not require any systemic steroids later on. Rather, from right now, the locals, the topical steroids are not going to penetrate because all sinuses are choked. Because the only thing which works here in this disease is steroid. And right now your only option is oral steroids to control the symptom. The moment you do a full house FES, open up everything, and then the topical steroid will penetrate, and then there is no need of giving oral steroid after some time. So that is our goal. So the goal of surgery is not everything, is not the cure. Goal of surgery is to reduce this inflammatory load, to make the topical steroids penetrable and to facilitate the medical treatment much better than now. That is the goal of surgery. And that is how we have to counsel the patient. If you counsel the patient that we will operate, you will be all right, it's a joke. Biggest joke. The role of surgery is to facilitate medical treatment. That is the goal of surgery. Any other question?
Yes, Satish, what is the serum IgE level of this patient? And
this patient IgE was significantly elevated. Yes, he has a eosinophilia, serum eosinophilia as well. We are going to get the tissue eosinophilia as well, as we are going to take a representative biopsy sample from one of the polyps or some mucosa. This patient immunologically, since is a young patient, operated earlier with this massive disease, we evaluated for the other history. He didn't have any history of asthma, so we ruled out AERD. Any patient with polyp with asthma, we must rule out aspirin sensitivity.
Yes, sir.
That is essential, otherwise you will miss a major diagnosis, a major endotype, because AERD, the kind of inflammatory spectrum in any sinusitis disease, the massive or the most severe is in AERD. The massive eosinophilia, AERD patient, the pathophysiology is in the reason is aspirin sensitivity and the COX hypersensitivity, COX inhibitor hypersensitivity leading to leukotrienes. If we don't correct that, if we operate the patient 100 times, he will come back again. It is bound to come back. So we have to target the pathophysiology. So we ruled out because of there is no history of asthma. And
so what about CRP and vitamin D?
CRP was normal. Vitamin D was low, already started in the sachets.
Okay.
Not significantly low, but it was low.
Okay.
We started and CRP was normal. There was no, that's why we stopped the antibiotic. 3 days.
Okay.
We started earlier for 3 days oral, then we stopped.
Okay, sir.
So this is not infective disease for that matter. This is inflammatory disease which is driven by certain cytokines. It has its own, the cascade of events leading to this clinical manifestation, and that's why the antibiotics have practically no role. Antibiotics can be used judiciously in the event of associated infection, sometimes to prevent secondary infection, post-operatively, and all those situations. But primarily, antibiotics are not the first line, treatment.
So what
You can
about the
carry on
dose
question,
of,
Paramita. I'm picking up. You can carry on. Yes.
Yes, sir. So what about the dose of doxycycline and how long? Dr. Rajat Jain is asking.
We give at least for 3 weeks, 100 milligram BD, and this is what evidence says. It has a role. It has a role in reducing matrix metalloproteinase is a important, cytokine in inducing inflammation and all, and that is something important. And many of the borderline polypoidal diseases, if managed properly with a appropriate medical treatment, using saline irrigation, judiciously using steroids, doxycycline, vitamin D, many of these patients we can even avoid surgery. But in such massive disease, even if you try to avoid, this is going to come back. The moment this will require steroids and again to control the symptom. That's why in the Western literature, the biggest indication for a sinus surgery now in such polypoidal disease is any patient requiring oral steroids again and again. To me, any patient requiring oral steroids to control his or her symptom more than twice in 3 to 4 months is an indication for surgery to make him use the topical steroids. That's it.
And so
But that is a straight away indication now.
Yes, sir. And so the histopathology, as you had said before, that the histopathology is important.
Yeah.
To decide the lifetime treatment.
Yes. The patient always is full of questions. How, when you start counseling that you need post-operatively steroid irrigation, you won't need oral. The next question will be how long?
Yes.
You don't know how long. You don't know the profile of the inflammatory profile of the patient. That mucosal histopathology, mucosal eosinophilia will give you the inflammatory profile, how much is the eosinophilia. Like for example, to me, Any patient having more than 10 eosinophil per high power field, I'll tell him, boss, you may need even lifetime. And mind it, don't try to get away. The moment you stop, you may develop the disease again. This is severe. So you have to take a call accordingly. This is something like in malignancy. You then know what is the, the immune profile, marker profile, the lymph node profile, the lymphovascular invasion, perineal, so many criteria that you get ultimately in the final histopathology, which warrants the adjuvant therapy. So here is exactly same. You can't say anything beforehand unless you have the full information.
Yes, sir.
Yes, so Dr. Devendra Rai, any other different methods by which you would treat these patients pre-operatively or post-operatively, any markers that you would follow? Yeah, you'll have to unmute yourself, Dr. Rai.
Boy.
Hello, yes. Frankly, I think very extensively placed by Satish.
Pardon, sir?
Exactly. I mean, we have to look for the inflammatory reasons why we are operating and what is the follow-up, because the endotyping is extremely important. I think these are the markers, and we also tend to do that. So I'm totally agreeing with that.
The most of the time,
yes,
the cause of failure in these patients is not the surgical. Surgical, yes, obviously, in this patient, the inadequate surgery is the obvious cause of failure. With this much of the inflammatory load, what the medical treatment is going to do? So, surgical causes of failure are obviously there, but inadequate workup, inadequate understanding of the disease profile is the major cause of failure.
I totally agree with you, Satish. The disease is basically a medical thing, and the surgery is to just open up the anatomy so that the therapy can be placed on a topical basis rather than a systemic one.
Yes, now the steroids, once you open up, the steroid will penetrate deep into the sinuses.
Yes. So I think we need to understand more medically today. And of course, surgically, yes, surgical skills are required, but medical treatment is at the forefront.
Yes. Can you see the picture now?
Yes, we can definitely see.
This is unprepared picture. We haven't used any topical or any infiltration or anything. This is the first picture with the introduction of telescope. Can you see?
Right. You can see the mucin coming out.
Yes. How is the picture, sir?
Picture is absolutely fine.
Let's put some white balance. Oh, so light come karna. कम करो. Yes, बढ़ा दो. Now see, this is the right side. The preparation, like Narayan asked, is very, very important. So that part of the pre-operative management, to give some steroids, saline wash, some antibiotic, is a different aspect. The goal is, whatever pre-operative preparation you do, pre-op or intra-op, the goal is to improve the surgical field, because this area is rich in vascularity, and too much of bleeding intraoperatively will prevent identification of your landmarks, and that is the major cause of either the disease, leaving behind the disease, or inviting complications. So the goal is to improve the surgical situation, and that's how the preparation starts way before. This intraoperative preparation is equally important. The reason is, in this intraoperative preparation, you have to further improve the mucosal condition, because the bleeding in this surgery is mostly because of the capillaries, not because of the larger vessels, unlike tumors like JNA and others, which are solely, where the source of bleeding is solely the larger vessels, arteries. Here are the capillaries. So you have to do certain maneuvers intraoperatively to reduce or to minimize the bleeding. This is what I'm doing. I'm using this Merocell. I generally do, you know what I do? See this 2 Merocell cut into different size number of pieces, soak them in solution of saline and adrenaline. This being a young guy, I'm using 1:1. In elderly, I may be using even less concentration, 1:4 or something, but always topical. We never inject. And it has been proven, we have even seen in our number of cases and literature, you see, the ultimate field is same, provided your pre-operative preparation is good and other parameters, the anesthesia parameters and others to take care of. So my first is this preparation with the topical saline adrenaline. See the field. And the second is to take care of the venous bleeding. You just keep the patient in the reverse Trendelenburg position by means of keeping the head end. We are keeping 15° up. And third is the anesthesia part, because here we are always grateful to our anesthesiologist to give us a good field. And what we want from them is the reduced cardiac output by means of reducing the heart rate closer to 60 or so, not the blood pressure. This is not arterial bleeding where blood pressure directly would have a significant impact. Rather, it can put the patient on risk if you try to reduce the blood pressure too much. So the blood pressure is not a concern. This is a benign disease. We can't afford to push our patient to unnecessarily cardiovascular risk by injecting adrenaline, which can go to the systemic circulation, or by means of lowering too much of the blood pressure, which can have its deleterious effect on the cerebral circulation, as well as on patients who are, cardiovascular liable patient, borderline patient. The reduced cardiac output can have an impact on the coronaries and can be a disaster. So we don't want the blood pressure to be low. We do in the normotensive conditions. What we want is the heart rate towards lower side. That is what we expect from our anesthesiologist.
Satish, what solution are you using for the decongestion?
The simple saline and adrenaline, sir. 1:1. 1:1.
Right.
But only topical. I am not injecting at all.
Right. And these Miracell packs which are giving.
Yeah.
I mean, I see that there is no thread attached to it. Do you think that is important, or?
Yeah. We the count is important.
Yes. Sometimes.
So, at the end of the surgery, see, I am removing the same pack. We rinse in the saline like this. Rinse in the saline is squeeze.
Right.
The same solution, and we can reuse again and again during the same surgery.
Absolutely.
At the end of the surgery, when you need the model cavity, use the same solution, the same packs.
Right.
So there is no additional, I can say, the financial burden on the patient as well.
True.
I'll be demonstrating inside. Yes, Paramita.
Sir, Dr. Kranti is asking about the role of macrolides.
Macrolides has a significant role, I would say. That's a good question from Kranti. Dr. Kranti Bhavna from AIIMS, Patna, is it?
Yes, sir.
So, but macrolides have proven their roles by means of having effects on certain cytokines, and those are involved in the neutrophilic activity. So this is more of a value in non-polypoidal sinusitis, where role of neutrophil is much more than the role of eosinophil. So macrolides to all patients with non-polypoidal sinusitis, for that matter, and in majority of those patients, we use clarithromycin, low dosage for 2 months, and we ensure before we starting is to have the patient's IgE low or normal. That is essential, otherwise macrolides are not effective.
Yes.
And once we use, the inflammatory profile is, drastically reduced. And majority of the patient, in our selected patients, we have been able to avoid even any surgery in those patients. Once the inflammatory load is lowered with the macrolides, you can continue with the saline irrigation and the topical steroid. See, it's a sort of trade-off between the inflammatory load and the need of surgical treatment. If there is too much of inflammatory load, you need to reduce by means of surgery to make your minimal medical treatment effective. If there is too much of the inflammatory load, whatever minimal treatment you can give with the steroids, your topical steroid cannot be so effective. So you can reduce the inflammatory load and continue with your topical steroid. Can you see the picture now? Much better?
Yes, sir.
Now what I'm going to do is I'm going to debride the polyps. I told you the turbinate is so compressed because of the polypoidal mass. Can you see here?
Yes.
That is the middle turbinate which has, the patient is having polyps on either side of the middle turbinate. You see this?
Yes.
And middle turbinate is so compressed. The micro debrider is an amazing tool. Be careful. Keep the cutting edges in view all the time. See this? This is the interplay between both the hands. Wherever your debrider is going, you have to give visualization through your opposite hand and keep the cutting edges in view so that you don't result into any significant damage. And see, this kind of messy polyposis, you have to be extra careful because it results into distortion of the anatomy as well. So here, and this is a revision case. See the middle meatal antrostomy?
Yes, sir.
In revision case, you have to be more careful about the landmarks because you never know what the previous surgeon has done exactly. And obviously the anatomy is distorted.
Yes, sir. So I would like to ask Brado, madam. Ma'am, what about your protocols regarding revision cases, ma'am?
Yeah, so I have a way of doing revision cases in a slightly different way.
Yes,
I call it actually step-by-step surgery.
Okay.
Not step-by-step, stepping stone surgery.
Okay.
That instead of going like we do in a normal FES, so uncinectomy, frontal sinus, then the bulla, and sequentially anterior to posterior, I first find one landmark, then I use that landmark to find the next one, and then it's not that you can very well do it this way, but especially when I'm teaching and someone who's junior and is beginning, they get daunted by the fact that there are so many polyps and I can't see where the uncinate is, I can't see where, sometimes you even can't see the middle turbinate. So the way to do that would be first to go along the floor of the nose and next to the septum, because that's the place which has no important structure. So you go along that, debride all the polyps along the floor and close to the septum all the way to the back till such time that you see the roof of the posterior choana. Now, no matter how aggressive the previous surgery has been, the roof of the posterior choana is always there.
Yes.
So you get an idea of what is the depth at which you're working. So when you start operating the other areas of the nose, you have always a comparison of the posterior choana to know how deep inside the nose you are. The next thing I do is, because we have removed the polyps, the next thing you can see is the inferior turbinate. Now, we know that the inferior turbinate lies just below the maxi-sinus ostium, right?
Yes. Yes.
Because in these revision cases, quite often the uncinate has been partially removed, either completely removed, partially removed. And if there are a lot of polyps, there's a chance that a novice surgeon may go through the lamina papyracea in trying to find the normal ostium.
Yes.
So usually the normal ostium has been opened, but you don't know what level the lamina papyracea is and where is the opening. So I usually open the maxillary sinus just above the inferior turbinate with an instrument which points anterior inferiorly.
Okay.
Once you open the maxillary sinus and you can see inside the maxillary sinus, you can see the roof of the maxillary sinus, that is the floor of the orbit. So now you have an idea of lateral to medial. So if the choana gave you an anterior posterior direction, once you see the maxillary sinus, you know where the maxillary sinus is open, the medial wall of the maxillary sinus. So you now know that the lamina papyracea will be either at the same plane or lateral to it. Because if there are polyps, it will have bowed out towards the orbit. So now you know, now that you have an anterior posterior and a medial lateral orientation, that's when I start removing the polyps from within the middle meatus. What I'm saying is actually the way I teach my residents. Okay, because
that is important, madam.